Editor-in-Chief, Journal of American College of Cardiology Imaging. Dr. Chandrashekhar, welcome you to chair the session. Along with
Thank you, Dr. Mahapatra. Look forward to be here.
yeah, along with Dr. M.S. Hiremath, everybody knows him, and he is the Senior Interventional Cardiology from Ruby Health, President of Cardiological Society of India. Dr. Hiremath, I would welcome you to chair the session. Then third, my friend, Dr. E. Prabhu, he is the Senior Consultant HOD, Department of Nuclear Medicine, Chennai Multi-Speciality Hospital, Government of Tamil Nadu, and he is also the past President of Nuclear Cardiological Society of India, and also the Tamil Nadu chapter. Dr. Prabhu, I welcome you to chair the session along with Dr. Chandrashekhar, Dr. Chandra, we call him short, Dr. Chandra, and Dr. Hiremath, the Senior Interventional Cardiologist. Over to you.
Thank you, Mahapatra. In fact, I'm very thankful for putting me in this eminent panel. Hiremath's plaque, as we all know, it is a very dynamic process. It has complex physiology and pathological composition, and has very important clinical implications. The general strategy in Hiremath's plaque imaging could be either we can view it from inside out or from outside in. To enlighten more about it, we have eminent Professor Jagat, whom we all admire for his knowledge and commitment to enlighten us more about it, its pathogenesis and the physiology of the plague. Over to Professor Jagat Narula.
Thank you, Dr. Prabhu. Let me start with sharing my screen first. And so can you see the slide?
Yeah, we are seeing you. Is it in the slide? Yes, correct.
Great. So it is indeed an honor, Dr. Prabhu, to be here, and thank you, Dr. Mahapatra, for the invitation. And also, I have the friends here, dear friends, Dr. Chandra, Dr. Manoria, Dr. Hiremath, and so many others. And looking forward to seeing Ashok also. So going with the first topic about the high-risk plaque, and as we have popularly called them as the popcorn plaques, the plaques that pop. So as we all know about these plaques, that these are the plaques which have a large necrotic core. If we see the large necrotic core, which is one of the most important features of the high-risk plaques, and they are normally covered by very thin fibrous cap, where the fibrous cap is less than 55 micron in its thickness in the plaques which have already ruptured, and about 85 microns or lower in the plaques which are likely to rupture. These plaques and these fibrous caps are significantly inflamed with the cells of the monocyte macrophage origin, as you can see here that the macrophages have been stained. Now, because of the presence of this large necrotic core, the plaque first grows outward, a phenomenon that was called the Glagovian phenomenon, or the phenomenon that was first described by Glagov, that the plaque first expands outwards until it has at least occupied about 40% to 60% of the cross-sectional vascular area of the vessel when the plaque starts to grow inwards. Now, we are able to identify these non-invasively, as we all know, by the CT angiography. And we are able to look at the plaques which have large necrotic cores, so the plaques which have low attenuation areas. And when it is less than 30 Hounsfield units, by the intravascular ultrasound, we found them to be correlating well with the large necrotic cores. So you can see here, for example, in the image B, that there is a significantly large low attenuation plaque area, which could be seen as the low Hounsfield unit densities here, as indicated by the red arrow. And then there is a significant positive remodeling or expansive remodeling or Glagovian remodeling, as we call it as. And we call these plaques as two feature positive plaques, the plaques that have large necrotic cores and those which have positive remodeling. On the other hand, the plaques which are stable plaques, these plaques, howsoever much stenotic they may be, they basically only have normally the fibrous area or fibrous attenuation, which is between 30 to 150 Hounsfield units. And we now also know if the people are not symptomatic, here the person had unstable angina, and if the people are not symptomatic and they demonstrate such plaques, for example, you'll see one in a patient who is not symptomatic or who was ruled out for any coronary event, you can clearly see a large necrotic core and a positively remodeled plaque, which is less than about 50% stenotic in this particular case. And he was let go and was on statins and was on antihypertensives. But 6 months later, he was found to have the acute event which was related to this particular plaque. So we are able to identify these plaques which have such two feature positive lesions. Now, in our study of a follow-up for about 2 years for 1,000 patients, we found that there was 22.5 times higher likelihood of having an acute event if the plaques were two feature positive plaques as compared to the plaques which did not have positive remodeling or which did not have an evidence of low attenuation plaque. On our follow-up of 3,000 subjects for 10 years' time, we found that the plaques which are so-called high-risk plaques, that is two feature positive plaques, they had about 10-fold higher likelihood of having an event as compared to those plaques which are the two feature negative plaques or the plaques which are so-called stable plaques. However, we must realize that the low-risk plaques also gradually grow, and there is a possibility that at least at the end of 10 years, half of the events occur because of the non-high risk plaques, suggesting thereby that the monitoring of these plaques and the primary prevention is extremely important or remains extremely important. Now, how can we improve our likelihood of identifying these high-risk plaques? So you would see that there are multiple ways by which we see that the likelihood of the predictability of these features improves. For example, this is the study from Dr. Newby's group. Michelle Williams recently presented in Circulation based on her Scott-Hart data that if the dose of the low attenuation plaque was high, for example, when the plaques were more than 4%, now somehow or the other we will have to take it with some kind of a fudge factor here, because 4% of the low attenuation plaque in my mind does not make much of an important sense, because at a lesional area, when we look at the prospect study, these plaques needed to have at least 25% of the area which was constituted in a plaque's cross-sectional area by the necrotic core. So essentially, we will have to use some kind of the factors here to compare the pathology with the CT, or to compare the pathology to compare the CT with the intravascular ultrasound. But regardless, if the low attenuation plaques were more than 4% as compared to less than 4%, there was a significantly superior predictability if we knew the extent of the necrotic core in these cases. In our study, we found that if these high-risk plaques were associated with significant stenosis, the likelihood of adverse coronary event was way higher, approximately 7-fold higher than the high-risk plaques which did not have significant stenosis, as you can see here. And then thirdly, which is the most important feature that we have observed, is the plaque progression. And about 500 cases out of 3,000 in our 10-year follow-up series, these patients had 2 serial scans, at least at 1 year interval. And we found that those plaques which demonstrated an increase in the plaque volume over the next 1 year, or we call them as the plaque progression. So if there is an increase in the necrotic core over the next 1 year, or there is an increase in the positive remodeling, these plaques have at least 35 times higher likelihood as compared to those which do not progress over the next 1 year. And even if the plaque was not a high risk plaque to start with, but demonstrate a significant increase in the necrotic core over the next 1 year, this plaque becomes or suggests that there is a sinister course ahead, as compared to the plaque which was a high risk plaque and that does not progress over the year, suggesting thereby that it has achieved some kind of a stability. These plaques have essentially no events over the next 1 year. Now, at the same time, when we are talking about the morphology of such plaques, you would also see that there is a significant amount which has been said for the FFR in these cases, suggesting that if the FFR is abnormal, you would have a worse outcome. And this has now become a gold standard for us to intervene in most of the cases. However, when you look at the FAME study 5-year data and compare it with the data which was presented by the same group in association with Dr. Habib Samedi, it demonstrated that the plaques of those subjects who had abnormal FFR and were treated by the optimal medical therapy over the next 5 years, the one who developed the events were those who had significantly abnormal proximal part of the lesion wall shear stress. As you can see here, that the wall shear stress, when it is more than 4.71 as compared to those which have less than 4.71, the likelihood of having an event is significantly higher. So if we say that the 50% of the subjects who do not develop an event or improve their angina also over the next 5 years, could these be the subjects who did not have a vulnerable plaque? To demonstrate this, we looked at the NXT data and we demonstrated that the FFR was essentially related to... Pardon? Okay, so the FFR was correlated to two things. One, obviously, as is intuitive, that it would be relating to the QCA, the percent stenosis. And the percent stenosis obviously would relate to the FFR, and you can see a significant relationship out there. And the second thing that it correlated with was the extent of the necrotic core or the low attenuation plaque volume, which also consistently showed a significant relationship with the FFR. Now, you would ask me that a plaque which is sitting outside, regardless of its stenotic value, why should that determine the likelihood of having an abnormal FFR? And the reason is that these plaques are maximally positively remodeled. Essentially, their smooth muscle cell layers are maximally stretched, and any amount of further dilatation does not dilate them further, while the proximal or distal parts of those lesions would dilate normally or at least better than this particular maximally stretched area, suggesting thereby that it would produce a dynamic stenosis, and you would have a significantly abnormal FFR in these cases. And essentially, that underlies the importance of FFR, that when the FFR is negative, you are likely to have a superior outcome in these cases. So what have we always thought? We thought that anything which is anatomically abnormal, we should just simply go ahead and revascularize them. And that has been the paradigm that has existed for many, many decades now. But with the Courage and Bari 2D and now ischemia trial, that demonstrated that the revascularization based on the anatomic stenosis alone should not be indicated. And then the FRAME group of studies has demonstrated to us that if the FFR is abnormal in such subjects, we would be able to have much superior outcomes in these cases. And essentially by doing the FFR, we are able to take away a bite of approximately 1/3 of the patients who may have significant anatomic lesion but may not require intervention. And here we suggest that if we add the plaque morphology on top of it, we would be able to even further reduce the likelihood of the revascularization further by 50%, suggesting that the revascularization only might be needed in 33% of cases. And in this paper, which is in collaboration with the very elegant work that comes from Dr. Ban Kwan Koo from South Korea, and the paper is currently under consideration in JACC cardiovascular imaging. It was found that if we look at only the anatomical model, as you can see here, the anatomical model only gives us almost quite like a flip of coin in terms of the outcomes. And when you add the FFR to it, there is a significant improvement. But if you add the morphologic features of the plaque, it adds to even the FFR, suggesting thereby that the anatomy, physiology, and morphology all would have a significant role to play. Now that we know that there is a less than zero point 0.8 FFR, and if the morphology is adverse, we basically should be intervening in such cases. But now there are a couple of questions which I would like to address before I end. The question first is that what if the FFR is more than 0.8, but you have got a significantly high risk plaque that you see in such cases? For example, you have got a huge plaque burden, or for example, you have got a significantly large amount of lipid sitting in the plaque. And that all emanated from the study, what is called the SCAPIS study, or which is indeed a registry in Sweden, and it's the Swedish cardiopulmonary bioimage study, where they were doing the CT scans in 5,000 subjects from the 6 university hospitals. So total of 30,000 CT angiograms are being done in such cases. And a random group of them have been taken up for the intravascular imaging, the angiography, intravascular imaging with the NIRS or near infrared spectroscopy, as well as with the intravascular ultrasound. So in this particular case, as you can see, that there is a 30% lesion and a 30% proximal LLE lesion, which has been confirmed here, and the IFR is normal in this case. What exactly should be done in such cases? And you would see this in the Prospect 2 study results, which are going to be presented in on October 14th in the TCT this year. And you would see that there were 900 cases, and Dr. Erlang and Dr. Greg Stone are the principal investigators for the Prospect 2 study. And those people who have more than 65% plaque burden, and there is at least one intravascular ultrasound confirmed lesion in such cases after their acute coronary syndrome producing lesion has been taken care of. In cases, the NIRS or the near infrared spectroscopy was also performed blinded. So let's presume that out of the 900 cases, 600 may not have another major lesion, and they will be followed up with the optimal medical therapy. While if we presume that 1/3 of them would have a significant lesion with more than 65% plaque burden, half of them would be treated with the guideline-directed medical therapy, while half of them would receive the absorbed biovascular scaffold. Now that you know that the biovascular scaffold has been taken away, question would be whether this would be an acceptable strategy. But the important point is that when we look at the pathology and morphology in the experimental animals, the everolimus eluting stents, in fact, do even better than the biovascular scaffolds when it comes to attenuation or passivation of the large necrotic codes. So here is the example with the biovascular scaffold, that you will see that 2 years after putting the biovascular scaffold, the entire lesion was converted into a stable lesion. And then the next study, which is going to be performed, is the PREVENT trial. And the PREVENT trial is being done by Sunjun Park's group in South Korea. Again, Dr. Greg Stone being a co-PI with him. And this case, because the previous one for the bioabsorbable stent, the arm that was not powered enough for the superiority results, these guys have gone with the much higher or much larger number of cases where the optimal medical therapy would be compared with the optimal medical therapy plus the drug-eluting stent or bioabsorbable stent, because in the midway, the bioabsorbable stents was dropped. So 800 cases to be compared with 800 cases with a follow-up of 2 years, and the results should be available to us by 2022. So the important thing is that is the guideline directed medical therapy important in such cases? So one of such cases here, you would see that a patient with chest pain, but only about 25 to 50% lesion in his left anterior descending after the septal second branch, but the FFR was significantly low in this case. And if you look at the necrotic core, there's a huge necrotic core in this case. The patient was put on 40 milligrams of rosuvastatin plus the ezetimibe. And as you can see here, that 6 months later, the necrotic core has significantly reduced and the FFR has become normal in this particular subject. So the question would be, who are the people who are likely to respond to these statins versus those who are not likely to respond? And in this study of ours, what is the yellow 2 study, we had seen that the people who were put on statins, they demonstrated a significant decrease. You will compare the left panel to the right panel, and that there is a significant decrease in the total amount of the lipid in within 3 months of time after the maximum dose statin therapy. And so what will be the predictability in such cases? So when we looked at their genetic profiling, looking at their monocyte before and after, peripheral blood monocytes before and after the statin therapy for 3 months, we found that there were 6 genes. There was a significant difference in their message, some which increased, some which decreased as those from the baseline. But if you look at the baseline, can we really identify as to who are those who are likely to respond as compared to those who are not likely to respond? And we find absolutely significant difference in the signature or their message profile, that we should be able to identify the people who are likely to respond to the statin therapy, and if they are not, should we take them for the next line of treatment or should we subject them to the intervention therapy? So I would like to end by showing this recent news, which you might have read from NHS, that NHS is to launch a mass trial of an as yet unapproved twice yearly cholesterol lowering injection, inclisiran. So 40,000 people with high LDL cholesterol are being invited to join in the trial of inclisiran by NHS via their general practitioners. The NHS has struck this deal with Novartis, which will offer the free injections in exchange for the results of the 5-year trial. And the cost effectiveness assessment will be performed by NHS themselves. And up to 30,000 lives could be saved over the next 30 years if inclisiran works as well as it is expected. More than 3 million people in UK suffer from atherosclerosis, and 2.5 million people are taking statins. The inclisiran will reduce the LDL cholesterol to half in 2 weeks. Then the then Health Secretary, Matt Hancock, said he was determined to find ways to save as many lives as possible and stop heart disease from taking people from their family and friends far too soon. The deal was announced by the NHS chair, Lord Priya, who positioned the NHS as the suitable large-scale test bed for the innovative medicines. So would this become our mainstay? Would we be able to reduce the cholesterol levels for our population to less than 50? And would we be able to avoid most of these instances? And when we are not able to do that, would we be able to identify the plaques which are likely to result in an event, and then identify those which are not amenable to any kind of therapy? And would the interventional therapy be indicated in them? Only the time is going to tell us. Thank you.
Thank you, Dr. Narula. That was outstanding. I've heard Dr. Narula speak many times, and each time I learn something new. So thank you. That was a fantastic talk.
Thank you, Dr.
Uh,
Chandra.
Dr. Hiremath, Dr. Prabhu, any thoughts?
Yeah,
And I'll have a
Dr.
question after that.
Yeah, Dr. Narula, we always give statin as the main drug for secondary prophylaxis. You said there are some ways to find out if statin is going to help somebody and if statin is not going to help somebody. So is there any way, I mean, a blood test, or is just the LDL reduction which should tell us whether it's working or not working?
Dr. Hiremath, it is $1 million question, and as always, you are very thoughtful when you give such comments. The important thing here is that currently we don't have anything in our hands other than just looking at the LDL cholesterol, and we should be bringing it to the minimum possible. And as there is no HIPAA violation here, and Dr. Braunwald himself very proudly says that his LDL is 23. And he says that he practices what he preaches. And he has done so as he claims he's the longest living person on the statins, because he started it as soon as he had presented his first trial on the statins. So actually the LDL levels is an important thing. I have tried my level best to reach to his levels, but I have not been. And I was discussing with Dr. Chandra the other day that I brought my LDL down to 29, and I've still not been able to reach the big man. So the big B for me. But would we be able to do it in future? Probably yes. Because when we look at our mRNA profiling of the peripheral blood monocytes, and that paper is in current consideration in circulation, where we demonstrated that there are a set of genes which go up and the set of genes which go down. And if we are able to figure that in the people, in those who are going to respond versus those who are not going to respond to the maximal therapy, there is a distinct difference of those which go up versus those which go down, or which are higher versus those whose expression is lower. And the possibility is that we may be able to identify that. And we have just started, it is Dr. Kinney who has been doing it. We have just started the Yellow 3 trial, where we are looking at a similar genetic profiling with the PCSK9, and we would be able to identify those people who are able to respond to the PCSK9 versus those who are able to respond to statins. So maybe that in the coming days, we have something more objective at our hands than just to look at the LDL levels in such patients. But until we find something, I think the goal should be that we bring the LDL levels to as low as achievable. The ALARA, which has been the nuclear medicine advocacy by Dr. Mahapatra, I think which should be also brought to the LDL levels as well.
The recent ESC guidelines, they have removed the word statin, and it is any way you bring down the LDL levels.
Exactly.
So obviously LDL is the target, and now not how you bring it down. So on that background, how do you put this monocyte response?
So that's why I was saying that it was the time when we presented our study about 2.5 years ago. At that time, the PCSK9 was not so easily achievable, and it was not approved by the CMS and FDA for the treatment of the people who were not familiarly hypercholesterolemic at that time. We were not able to use the PCSK9 at that time, but our Yellow 3 trial, we are doing it with the PCSK9, because the expectation is that the genes that it is working through would be different. So it would not be able to extrapolate the statin based response to the PCSK9 based response. and we will have to have a separate study to look at the subjects who are only on PCSK9, the subjects who are only on statins versus those who are on both of them, as is currently the recommendation. So you are
Jagat,
right
what?
that this peripheral message picture of the statins may not be applicable to the PCSK9 picture.
So, Jagat, you are one of the world's authorities in this area, so it would be interesting to hear your take on this. So, there are two streams of thought here, right? There's a whole group of people who want to go and image the plaque either intravascular or non-invasively. And there are another group of people who say, don't worry about all that. Just get the cholesterol down, get their risk factors down, and you will achieve more than anything else you can do by imaging. Where do you think the future is? Is there a happy medium where there'll be some proportion of imaging and some proportion where, obviously the larger proportion, where you just treat to risk rather than treat to an image?
So, Dr. Chandra, again, as thoughtful as you are, and you are the one who has addressed this question multiple times, and I always admire your lectures on this, and that's why whenever I invite you for the lectures, my request always is to address the same issue. And so I think both the groups, I think, although they try to demonstrate that they would be able to exclusively suggest one or the other, I don't think that there is any way of going for one hypothesis, whether as compared to the other hypothesis. And as you said, that there will have to be a happy media. We have got to work with the treating every single one and bringing the LDL down. There is no doubt about it. And as a matter of fact, what is required is to bring the LDL level down for the community. And the reason that we have got to do that is that when we call ourselves with the normal cholesterol levels, these normal cholesterol levels which have been established for the population which is at high risk of developing the vascular events. So these are the usual levels of cholesterol, and these are not the normal levels of cholesterol. This is the population at risk of developing. So at risk of developing the vascular events. So we have got to bring down the levels. That is number one. There is no doubt about it. The second important thing is that we don't have to go for the secondary prophylaxis. And even if we have got to go for the secondary prophylaxis, we have to change the definition of the secondary prophylaxis, as we had recently presented in JAC, where we wanted that the secondary prophylaxis definition needs to be changed. Once we have seen it on imaging that there is the presence of atherosclerosis, that becomes a secondary prophylaxis. We don't have to wait for an event to call it a secondary prophylaxis. And the third important thing would be that there will be people who will still develop. And we do know that after giving the statins and after maximizing statins, and even after giving the PCSK9 on top of the maximal statins, we still develop events. So the disease is not gone. There is a genetic basis also. There is environmental basis also. So I think that we will have to find at least a group of people where the imaging will need to be done. Now, question only is that how exactly do we change our risk factor profile? Or how exactly we find which people need to go for an imaging would be the most important challenge to us. The reason is that if we saw last year's paper by Salim Yusuf on in the ESC, and the paper was in Lancet simultaneously, that the risk factor profiles are changing. It is the air pollution, which is more important. It is the obesity, which is more important. It is the lack of physical activity, which is more important. So we really need to come up with a modern risk factor profile, and we need to identify those subjects who are likely to develop an event which we should be able to subject to imaging, and then decide whether they would respond to the medical therapy, or should we be doing the medical therapy as well as an interventional therapy in such cases. So happy media will have to be found, and I think we need to learn a lot more than we know today.
Thanks.
Dr. Jagat, this
Excellent
is,
answer.
Sorry, can I ask one question?
Yeah, please.
The ACC has sort of indicated that anybody who is crossing 70 years of age, irrespective of LDL, should have statin. Now, we know that it's the drop in the LDL levels as well as the duration or the length under the curve, which is very important. So together, they make a better impact than just a drop for a little while. So why not 50 instead of 70?
I mean, why not 30 instead of 50? I mean,
Exactly.
I would even say that. And because of the lack of time, I did not want to show one of the very recent figures that we put out in JCC in the JAC, where we try to demonstrate that there is a gradual increase of the plaque volume in the arteries until it reaches mostly, and that can happen earlier or later in a given subject, but about 50s or 55 years of age, when the event is about to occur, you basically see a sudden takeoff of the necrotic core volume increase. And that is the harbinger. Within the next 6 months to 1 year's time, you have an event. It is very important to catch that period when we are trying to avoid an event if we have not treated earlier. And exactly as you say, Dr. Hiremath, that if we had treated them earlier, we would not have reached that stage that this sudden increase in the plaque volume would have occurred. So we basically, our end point is that sudden increase in the plaque volume, and we have got to prevent that. Now, how do we do that? Either we have to find a way of identifying that, or we have to keep the area under the curve, exactly as you are saying, the so-called pack year cigarette consumption. That is the something that we really have to look forward to quite similarly in the cholesterol as well. So you are absolutely right that why not start early, and that is why if we would and there is one of the paper of ours which you would be seeing with the European Society of Cardiology meeting coming out in European Heart Journal, which I have been lucky to put together with Dr. Tom Lucier, who is the editor of European Heart Journal, and Dr. Joe Hill, who is the editor-in-chief of Circulation. So three of us have put it together with one of my colleagues, that the prevention does not need to only start in adolescence, which Professor Fuster has always said. We have gone a step earlier, and we have said that the prevention starts the day we are born. And we have tried to present a compelling evidence that this area under the curve needs to be controlled very exactly as you are saying.
If you analyze the ischemia data, I think the big loser are these physiologic testing like stress thallium, and big gainers are the CT imaging, which actually tell you something more about the vessel wall. So I feel it's very true to begin the prophylaxis. So you think, like Scott Hart indicated, that even a general population should undergo CT scanning. So it's a good idea, or?
So, Dr. Hiremath, again, it's a very important question that you said, and I have my biases, obviously, but having belonged to the imaging community, although I now feel less responsible now that I'm no more the editor of JAC Imaging, so my statements can be the personal statements, and I don't have to be as cautious as Dr. Chandra has to be now, because his every statement can be taken with a lot of political weight also. So I have my definite imaging bias, and I certainly would like to go with the CT as one of the important ways of doing it. Problem only is that how many people can we really do with it? When it comes to the coronary calcium scanning, yes, that is a possibility, because it may stand true for the cost effectiveness if even if we needed the entire population beyond an age to be taken over for that. But now there are some very decent data that you would be seeing from Dr. Leslie Shah, where you would find that with the absence of the coronary artery calcium, we may be losing a lot more than what we used to think earlier. We used to think that only about 5% of the people we will be losing, but here it may go to about 40+% of people, which may have significant atherosclerosis, which we may miss if we are not, if the calcium is, if we base everything on calcium. So power of zero may not essentially be that as we used to think, but would we be able to do CT angiogram? And if we would be able to do CT angiogram, how many times would we be able to do CT angiogram serially, so as to find whether a person is progressing or person is not progressing? And he may be progressing either because he is not taking medicine and he's telling you he's taking medicine, or because the medicines are not working on him. So basically, all these questions would need to be answered. And I do not think that, at least for now, I am in a position to be able to make a comment on this so effectively. But yes, when a patient comes to me with a significant risk factor profile, I would never hesitate to do a CT angiogram on a person, specifically if the person is able to afford a test.
When we see something on a CT, we focus mostly on LDL, statin, PCSK9, or now inclisiran probably. So what about the other therapy like blood thinners, like antiplatelets? Now we have dual pathway inhibition with vascular dose of rivaroxaban. So can CT guide us on adding on these in addition to LDL reduction?
So CT per se would not be able to say much in terms of that, but essentially, if we are going to go for at least for a secondary prevention part, when you will look at the IMPROVE-IT trial and things like that, you basically did see that the use of dual therapy there was more because of was beneficial because of the new areas of the event rather than the one which was stented earlier. So
New
basically,
culprits.
in such cases, certainly possibility of using the antiplatelets and all could be of more help. I do not think that by looking at the morphology of a lesion, I would be able to say that this is one particular lesion that is going to be benefited more. Yes, if there is a possibility, and again, it is just a conjecture, that if we are able to identify something which we think it is imminently dangerous, that this is something which is going to result in an event, would I like to use a dual antiplatelet therapy there, or would I really like to go into intervention? That would be anybody's guess.
Dr. Hiremath, I think we should go to the next talk, and all the questions from now onwards will be at the end. Otherwise, you will not complete the another 7 to 8 speakers who are there. So that's a request to the chairpersons.
Thank you.
Okay, so this is a good time to segue into CT. We should probably introduce the next speaker, Dr. Priya Jagia from All India Institute in New Delhi. She's going to talk about unstable plaque evaluation by CTA. Dr. Jagia, please.
Unmute.
Has somebody muted us?
No, Dr. Jagia has to unmute.
Okay. Can you unmute as an administrator?
Yeah. Sorry,
yes.
sir.
Got it.
Yeah. Thank you, sir. And thank you, Dr. Mahapatra, for giving me this opportunity to speak about this topic of unstable plaque imaging on CT. And I'll start sharing my screen.
Hi.
I hope my screen is visible to everyone.
Yes.
Yeah, actually, part of my talk has already been discussed by Dr. Narula. So I'll be as we all know, when we are talking about ischemic heart disease, can we have this waiting room notification not coming to me in Nikita, please? So when we are talking about ischemic heart disease, our primary focus is on primary and secondary prevention, and we want to actually identify the patients who will benefit from the preventive therapies. So when we talk about imaging in a patient having coronary atherosclerosis, we obviously do want to know about the luminal stenosis, whether it is obstructive or not, but we also would like to have an idea about the plaque burden, characteristic of the plaque, its morphology, ulcerated or not, ruptured or not, and also identify the high-risk features if they are present. On the basis of this, we would like to prognosticate and also follow up these patients, and this would then further management. So this is all what we need from an imaging. So when we talk about angiogram, coronary angiogram, the classical way of seeing the coronary artery has been the catheter angiogram, which shows only the patent lumen. But when we talk about a corresponding CT image, you can not only see the lumen opacified, but also the plaque very well. So it is time that we start now asking for a CT angio report, wherein not only the lumen is mentioned, but also the plaque and the plaque characteristics are mentioned. Since we all know, it has been reiterated many a times over, that it's not the just the stenotic plaques, the obstructive plaques, which cause majority of the fatal MIs and ECS are caused by the non-obstructive plaques, which are vulnerable. And when we specifically talk about coronary CT angiography, it allows you a plaque morphology assessment, wherein you can, based on the Hounsfield unit, we are able to assign whether it is a fat, whether it is calcification, which we are seeing. So you can have an idea about the plaque composition. You can see the plaque attenuation and the pattern. You can pick up spotty calcification and positive remodeling, which Dr. Narula discussed and which I'll be alluding to also. And obviously, we are going to talk about this obstructive stenosis, whether it is obstructive or not. Then, since it is a 3D reconstruction can be done, volumetric analysis can be done, hence it is possible to quantify the plaque burdens. And hence it is now possible to think of some scores which are incorporate the plaque burden volume in addition to the risk factors and also the stenosis significance, which can be used to prognosticate a lesion. CT actually is one of the best non-invasive modality to have a look at the plaque because of its sub-millimeter isotopic resolution. We have now with good scanners, we have a dual energy scanner in our institute. So with those, we have a spatial resolution which is less than 0.3 mm. So it's 300 microns or lesser. So it's almost approaching to IVUS levels. So it's possible to non-invasively see these plaques, have the detection, characterization, and quantification. And this is a study which was done, it was published in 2011. And at that time also, it compared to the IVUS, the CT angiogram showed a good diagnostic accuracy with the sensitivity and specificity in 90s. So you can expect even better diagnostic accuracy with better scanner available nowadays. Briefly, I'll be alluding to the most commonly reported plaque characteristic, that is the CT calcium score, because Dr. Johann is going to talk about it. So I have just 2 slides to talk about calcium score. It quantifies the macroscopic deposits of the calcification, like we all know, and it is a very powerful prognostic factor which adds an incremental value to the cardiovascular risk factors. And what is important is the power of 0, which is a powerful predictor. So in an asymptomatic patient, if the calcium score is 0, there is a very, very low risk of patient having a cardiovascular events. However, one must remember again, like Dr. Narula said, it does not completely exclude ACS because there could still be non-calcified plaque which may dispose to event. 2 large studies about calcium scoring. This is a study by Budoff et al., which had 25,000 plus patients, and which showed that there was a survival variance based on the calcium score coronary calcium score. So the survival rate was 99.4% with scores of 0, and it dropped down to 87.8 with scores of 1,000 and above. Another very large meta-analysis with 13 studies with 71,000 plus patients. These are asymptomatic patients. So in these patients, the patients who did not have any calcium had much lower cardiovascular events of 0.47 versus higher event rate with calcium score, with increased calcium, coronary calcium. So what should we look for? Should we look for just presence of plaque, the volume of plaque, the location, the characteristics? So what is the type? What is it? So all of these are important. So when we are talking about the powerful tool calcium score. But one must remember that calcified plaques are the plaques actually which are relatively unlikely to cause clinical events. So what is also important is to also have an idea about the plaque and pick up the vulnerable plaque which is likely to rupture, the plaque which is at risk. And that can be done when we can have an idea of anatomic assessment of the plaque composition. And secondly, if we can have some molecular information about disease activity. So when we talk about these two aspects, the first aspect is very well, satisfied by the CT angiogram. So when we talk about the CT features of vulnerable plaque, when the CT features include positive remodeling. So what is meant by positive remodeling is when the diameter of the vessel increases in the region of the plaque and the diameter becomes more than what it should have been in the usual, along the usual expected contour. So this is positive remodeling. And in this case, you can see there is a dark attenuation plaque in this region. And a cross section through this will give you a picture, which you can see here, the C panel. So this is a typical napkin ring sign. So what you can see here opacified is the contrast opacifying the lumen. And this is the hyperdense margin. And the center is a low attenuation of the plaque. So this is the napkin ring sign, which is again a powerful, significant indicator of a plaque which is vulnerable. The third feature which is suggestive of vulnerability is spotty calcification. This is small calcification, less than 3 millimeter in size. So spotty calcification again is a harbinger of a vulnerable plaque. In addition, CT can also pick an ulcerated plaque, which again again is suggestive of a patient who is going to have event. So then there are many papers which have talked about. Dr. Narula has also talked about so many papers. This is one of a large meta-analysis which was published in Circulation in January 2018. It included 13 studies with around 14,000 patients, of whom 4% had MACE. The follow-up was at 8 years. So what it looked at was it compared the strength of association between the CT angiography derived characteristics of the plaque versus MACE, and it looked at two features. First was whether the lesion was calcified, partially calcified, or non-calcified. And obviously, as expected, the strongest association was observed for the non-calcified plaque with a hazard ratio of 1.45. And there were weaker association with a partially calcified or a calcified plaque. The second thing which was looked at was the high-risk plaque features, which we discussed: the low attenuation plaque, napkin ring sign, spotty calcification, and positive remodeling. And it was found that all these high-risk plaque features were strongly associated with MACE, and of these, the napkin ring sign was having the highest hazard ratio of 5.06, which was followed by a low attenuation plaque. Again, actually, the napkin ring sign is a manifestation of low attenuation plaque itself, positive remodeling, and then spotty calcification. And also, it found that if the high-risk features were, there were additional high-risk features, the features were two or more, then these patients had even higher risk of MACE, and the hazard ratio increased to 9.17. So this data clearly showed that the high-risk plaque features are an independent predictor of MACE, and it clearly mentioned that now this is the time when this should be clearly reported in the clinical practice. However, it mentioned that at this point, it remains unclear whether this reporting will have a clinical implication now. And now we have many studies which are now looking into the fact whether, picking up a plaque, vulnerable plaque will have a clinical implication or not. So this is how it looks like on CT. This is a non-calcified plaque, which you can see here. This is a partially calcified plaque, less than 50% of the plaque. And this is the calcified plaque, which is almost the entire plaque. So more than 50% calcification is there in the plaque. A low attenuation plaque is a plaque. So what we do on CT is we can measure the Hounsfield urine, that is the density of the tissue. So that gives you some little bit of tissue characterization. So this is less than 30. So this means this is a fatty plaque. So this is the plaque which is vulnerable. Spotty calcification, like I mentioned, less than 3 millimeter. Positive remodeling, again, you can see here positive remodeling. So diameter is more. The obstructive lesion is underestimated in these cases. The napkin rim sign, heterogeneous fibrofatty plaques. So these are the things which should be mentioned in the report, and you should seek them out when you are asking for a CT angio. So it's time we started moving beyond the stenosis. This is the ROMICAP trial, which was published in 2014. It again said that in patients who had high-risk plaque on coronary CT angiography, there was increased risk of ACS independent of the significant stenosis when the patient was symptomatic. This is a large iconic study, which was published in 2018 with 25,000 plus patients, and they had 129 culprit lesions who were identified to be the precursors, culprit lesion precursors. And of these, actually what they found was around 2/3 had actually non-obstructive CAD at baseline and still had ACS, and 52%. So around half of them had high-risk plaque features. So it again came to the conclusion that the high-risk plaque features, along with plaque burden and plaque composition, identifies the high-risk patients even beyond the presence of obstructive stenosis. Dr. Narula alluded to this trial. So this is Spot Heart trial in 2020, actually. So this talked about patients with stable chest pain, and it studied the association of the future risk of MACE, of fatal and non-fatal MI, and association with the low attenuation plaque, the risk scores which are traditionally followed, calcium score, and obstructive. So all these four were seen with the MACE, and it was found that the low attenuation plaque volume, again, was the strongest predictor of the future myocardial infarction, irrespective of the rest of the three features. And if the low attenuation plaque burden was greater than 4%, there was more than 5 times risk of having future MACE event. So these findings actually challenge the current perception of supremacy of using classical risk factors for predicting the events, including the stenosis severity also, which is classically followed. This is a CAPI trial, which again is published in JACC CVI in 2020. So again, this again talks about it took into account the Framingham risk scores. So low risk clinical risk versus high clinical risk. Actually, they excluded the diabetes. And again, the outcomes were the MACE. And again, they looked at multiple parameters: arterial remodeling index, plaque burden, napkin rim sign, spotty calcification, the length of the plaque, presence of low attenuation plaque, total volume of the plaque, and the fibrofatty plaque volume. So these were followed. And what was found was that the MACE event rate was same in low calcified, non-calcified plaque volume. So irrespective of the presence of multivessel disease or increased risk score. However, when the non-calcified plaque volume was high, so the event rates were much higher, again, with both either multivessel disease or the high risk score. So it found that the high non-calcified plaque volume is the most ACS predictive parameter which can be used in patients with extensive CAD. So this is the editorial comment. So the plaque imaging is really hot these days. So this is the editorial comment. So talked about. So I just quote the words which he wrote. So it's time to move beyond the negative space of human stenosis to integrating the features of totality of the plaque features in coronary atherosclerosis. So what does CT offer you? So CT can show you those vulnerable plaque features. So what is new? What is coming out new is that we now have tools to do quantitative analysis of this plaque. We can actually, using color-coded maps, using against the Hounsfield's unit, it is now possible to define the plaque as low attenuation plaque, which is seen as red, then intermediate plaque, which is seen as light green, and dark green is the high attenuation plaque. So you can see them, you can quantify them. In a cross section, you can see what is the red area. This is the fatty plaque. This is light green area. Again, this is intermediate plaque. So you can see the composition at a particular level. You can exactly quantify the volume of the plaque also. So this is another patient in which quantification has been done. So you can clearly see how the volumes can be measured out, and you can have a chart. And this, because this is reproducible chart, this is not operator dependent like ultrasound like IVUS or OCT. So this is something which is very, very reproducible and can be used for follow-up of the patient and to look at the plaque progression, which again Dr. Narula alluded to. So the presence of significant stenosis and high-risk plaque was evaluated in this study, which was published again in JAG 2015. So this was around 450 patients. And again, it found out that the plaque progression, when detected on serial CT angiography, was an independent predictor of ACS. Talking about when to use this, even I have a doubt in mind. And when is it the time when we should start using plaque imaging, CT plaque imaging, non-invasive plaque imaging in asymptomatic patients? And probably I'll talk to Dr. Narula about later on. But this is a study which talked about asymptomatic diabetic patients. And then again, they talked about the plaque progression, and they found that the low attenuation lipid-rich plaque volume showed the highest predictive value. And the quantification derived from the non-invasive.
I'm in the meeting.
Got tended incremental prognostic value. So again, there are some group of patients who, because of their high risk factors, may actually need plaque imaging. Then the second thing which is possible on CT is, with the advent of dual energy CT, what we can do is we do CT using two different energies, like at 140 kV or 100 kV. So this is a study which talked about 20 patients who underwent dual energy CT and virtual histology IVUS. So what we do is, at different energies, the fibrous tissue and the necrotic tissue, they behave differently and they show different sort of images. And using those differences, it is possible to have a dual energy index, which can help differentiate the necrotic core from the fibrous plaque. Because since both of them may look dark on the CT. So dual energy CT is a new thing which is there and which can help actually further characterize the plaque into fibrous or necrotic plaque. Then another thing where a lot of work and research is going on is on computational fluid dynamics. We all know about CT-FFR, which is using the computational fluid dynamics. And similar to this dynamics, use of this in FFR, it is now thought possible that we will be able to probably quantify the plaque stress. So to see the wall shear stress. So you have a plaque which is there. This is a thin fibrous wall, you can see. And this is and identify which are the plaques which are at risk of rupture. However, all said and done, though it's a non-invasive modality with a reasonably good spatial resolution, however, this spatial resolution is still not in the range of what we need to look at the thin fibrous cap, which is usually less than 65 micron. What we have is around 300 microns with CT. It's not what we see with OCT, which is the best for visualizing this thin fibrous cap. Second thing is, depending on the injection speed, the type of contrast agents, so it's difficult to actually come out with a definite cutoff threshold of the CT value for defining the low attenuation plaque. So reproducibility at the moment is still not Very good. What we need is to actually have some protocols based on which you can have some reproducibility. But all said and done, CT, because of its operator independence, is a fairly reproducible. So when we talk about comparison of different plaque imaging modalities, if you look at CT, like I said, the spatial resolution is 300. So you can see it's fairly good for visualization of the lipid pool. It's excellent for visualization of calcium, but it is poor for visualization of the fibrous care, where this OCT scores in most of the region. And however, that OCT and IVUS are both invasive procedures, and doing them for patients who are asymptomatic or who are at lower intermediate risk actually is not worthwhile. So I would like to end by saying that it's time that we move beyond stenosis and we started looking at the wall and paying respect to the plaque characteristics also. It's important that we identify the adverse plaque features and quantitatively measure the plaque volumes. And for now, CT angio probably can be used for non-invasive plaque evaluation of patients who have low to intermediate risk factors, in whom actually the invasive imaging may not be warranted. Thank you.
Thank you, Dr. Jagia. That was an excellent talk. And as Dr. Mahapatra said, we'll take the questions in the end. Dr. Hiremath, would you like to introduce Dr. Christopher?
Oh, yes. Dr. Christopher Jonathan comes from Hyderabad, and he's a very prolific on the Indian scene as well as overseas scene whenever these kind of meetings are held. I always enjoyed listening to him, and he has an excellent correlation of what you see on CT and what you see in the cath lab. So it would be exciting to hear him on this particular topic, the coronary calcium scoring. Dr. Jonathan.
Good evening, sir. Thank you very much, respected chairs. Thank you very much for this opportunity. Today, I will be talking about the coronary calcium scoring. And you can see historically that we have depended on various factors for looking at the prognosis of coronary artery disease. From time immemorial, we have been looking at the angiographic findings, single vessel versus triple vessel, to look at prognosis. And obviously, triple vessel has the worst prognosis. We then looked at whether the LAD was involved or not, and we clearly showed that an LAD involvement was important. And then we finally moved to a hemodynamic evaluation where somebody with heart failure had a worse prognosis and somebody with an uncontrolled blood pressure had a worse prognosis. So we have come a long way from there. And today we have the Framingham risk score, which looks at a number of non-invasive parameters, historic and blood, to get a fair picture of the risk, 10-year risk of developing heart disease in somebody who's named. And you do get a risk level on which you act based on the medication or you have an invasive evaluation. But in 2009, a significant change happened with Dr. Philip Greenland and his group from the Northwestern University, where for the first time they demonstrated in about 6,000 odd patients that by looking at the calcium score, the coronary calcium score, they were in a very powerful position to predict risk over and above the risk scores that have been clinical risk score that have been developed, and that got them a mention in the Time magazine in 2009. And what it did entail was, apart from the conventional parameters that we all take at the clinic, you would be able to add the coronary artery calcium score, and you were in 25% of patients able to move the 10-year risk from a low risk to an intermediate risk, or in other words, an intermediate to a low risk, and thereby give us a better risk calculator in terms of treating our patients. Now, what exactly is coronary artery calcium? Calcium in the coronaries is part of the development of atherosclerosis. It is found exclusively in atherosclerotic arteries, and it is more frequently seen in advanced lesions in older age. However, the relation between the coronary calcium, the percentage of stenosis, and vulnerable plaque, which Priya did mention, is non-linear. In the 1980s, we were doing EBCT, which was basically a fixed scanner, which did not rotate, which had a very good temporal resolution. But by the beginning of the 21st century, with the multi-slice CT scanner, EBCT became a thing of the past. And then now we use multi-slice CT scanners, which not only look at calcium, but we're also able to look at contrast scans, vulnerable plaques, as Priya did allude to. But what is important is that the radiation levels, which we're all very worried about as clinicians, is extremely low in the modern multi-slice scanners, from anywhere between 0.45 to about 1 millisievert, even in a hefty individual. So the radiation dose is quite low, and that also addresses some of the discussion that Dr. Hiremath had as to should we apply calcium scores to a larger part of the population. Possibly, yes, with a newer generation of scanners and very low radiation. And how is it done? Well, it is a non-contrast spiral scan, which takes just about 5 seconds to do with no special preparation whatsoever. And the data which comes from this scan is then fed into the computer, and then you would have an automated or a semi-automated way of looking at the score. What is also very important is that we look at the density factor, which seems to be a very important parameter over and above the Agatston score. So we take the Agatston score divided by the total area of calcium to get the density factor. And it has been seen in various studies that apart from the Agatston score and the volume score, which may be similar, the lower density has been associated with a higher cardiovascular risk. And that seems to be an important thing. Now, when we interpret the coronary calcium score, this is the standard interpretation that we use, where a score of 0 basically means no identifiable calcified plaque, and the chance of you developing heart disease is extremely low. It moves up to 1 to 10, 11 to 100, and 101 to 400, which is moderate. And then finally, anything above 400 means a large amount of plaque is present, and you are at a very high risk to develop heart disease. In fact, when they did studies, they found that anybody above 400 had a 50% nuclear scan, which was positive. And so in many labs between 400 and 600, these patients, actually you stop the calcium at the calcium level, you do not proceed with the CT, and then you send this patient to the cath lab, because these patients have an extremely high chance of having a treatable lesion or a lesion more than 50%. And this is done to optimize the radiation, the contrast, and also the cost in today's era. So this is a patient who had a 0 score, as you can see in the calcium scoring. He went ahead and got the CT with the contrast, and you can see very pristine coronaries in all the 3 vessels. And this patient had a 0 score and absolutely no other lipid or non-calcific plaque at all. Contrast this with another patient who has an extremely high calcium score of about 1600. And you can see when we did the CT, there are multiple lesions in all 3 vessels, which are fairly significant on CT. Went ahead and did an angiogram, and this patient had a triple vessel disease and had a revascularization done. So calcium score guides us in performing the CT and sending specific patients for a revascularization. Now, whom do we do calcium scores was? And this is clearly seen from various guidelines that in asymptomatic patients with the Framingham intermediate risk, that's a 10 to 20% 10-year risk score, it is ideal. However, in the low to intermediate risk of 6 or 7.5 to 10, it can be done. But however, it is not recommended for patients who have a low 10-year risk of less than 6%. These patients should be directly managed according to their clinical risk and managed as primary prevention. So it is a very specific group of patients that really need to undergo this test, and that's a good way when you apply it at a population level. Now, if you look at the algorithm for asymptomatic patients, we look at the 10-year clinical risk of MACE. We do not do calcium scores for low risk, nor do we do it for extremely high risk patients. These patients either get a CAT done, or they get a functional study, which could be either SPECT, dobutamine, or an MR study. However, it is the intermediate risk, and this is something I would like to focus on for our audience, 10 to 20% 10-year score, wherein calcium scoring is very, very useful. And based on the score, if it is less than 100, you continue with primary prevention. If it is more than 100, as I said, there is a high chance to have a lesion more than 50%. So they would either have a nuclear scan or directly go to the cath lab, depending on what is the protocol in your institution. However, it's the 100 to 400 intermediate calcium score with aggressive secondary prevention can be applied, which leads to very favorable outcomes. Now, if you look at the 2007 American College and AHA Writing Committee, if you look at the 2013 Guideline Committee, all clearly put the role of calcium scoring once you have a assessment done, a 10-year assessment for atherosclerosis, and then for whatever reason you're unable to come to a specific treatment decision, you could use either a strong family history, a positive HSCRP, or a calcium scoring. And this is exactly where the calcium score really fits in into the clinical risk stratification score. Now, if you look at the two barometers, and this is a question which is often asked, should I use calcium score versus CIMT? If you look at the probability here, here you can see that the calcium score is very amenable and also has a significant risk stratification for cardiovascular disease, but it doesn't do so well for patients with cerebrovascular disease. However, the CIMT in red has a lower threshold for cardiovascular disease, however, performs very well for cerebrovascular. And if you look at the anatomy, it seems quite reasonable. So the calcium score is highly sensitive for the presence of stenosis. However, it is only moderately specific. And this is where the drawback lies in the calcium score. And the various meta-analysis shows a sensitivity of almost 91%, but only a very moderate specificity of 49 or 50%. What is important is the negative predictive value, that if you do not have a calcium score of 0, it means the chance of you having a significant lesion is less than 1%. We look at special populations where this possibly is not applicable. Now, it is also important as clinicians to know what the limitations are. Now, in the current scanners, we have a certain bore size. So somebody who's extremely obese or extremely large cannot really fit in, and it would not be feasible to do a scan. Anybody less than 50 years would have a higher proportion of non-calcified plaque and may not be applicable as a population-based study. Health insurances always have a problem in allowing for billing for calcium scoring, even in our country.
It's coming on the slide. Can't we take it?
A higher heart rate, again, may interfere with the image quality of the test. And also, the exact treatment protocol for a very specific calcium score is not very clear. There are also situations where you do not do a calcium score, and that is in pregnancy, somebody who has already had a prior myocardial infarction, a prior stent, or a prior bypass surgery. There is really no role for calcium scoring. Somebody who has a heart rate of more than 100 in a 64-slide scanner, you're going to get artifacts, and possibly the accuracy is going to be limited. Any cardiac implants, whether it's pacemaker or a mechanical heart device, is obviously going to be a major problem with calcium scoring. So this is important when we send patients for the calcium scoring. The accuracy trial really put calcium scoring into the limelight, which clearly showed a very good, a very high sensitivity with a very moderate specificity, which increased only when the calcium score exceeded 400. The MESA trial again looked at calcium score as a very important risk parameter, and it found that whatever race you belong to, whether white, Chinese, Hispanic, or Black, calcium scoring has an important bearing, the relative proportion of which would be a little different. For example, in whites, it was more, both white men and women. But however, in whatever race you looked at, calcium score has a similar bearing. In asymptomatics again, as your calcium score moves up in the 4 tertiles, and the highest tertile, the risk is extremely high, and this was data done on the elderly population of more than 65 age. In the same FRS group of 10 to 20%, you can see that there are 3 tertiles of risk, in that the first tertile is somebody less than 100, the second is somebody less than 400, and the third is more than 400. So in the same FRS score, clinical score, you could actually divide the population into 3 groups based on their calcium scores. And the NEGM article a decade earlier clearly showed that the higher the calcium you would have, the higher chance of coronary events, clearly putting it on the map of risk stratification. The Agatston score and the stenosis score with age clearly showed that men with significant stenosis generally had a much higher calcium, women also similarly with significant stenosis, but those with mild stenosis less than 50% had much lower calcium scores, just putting the perspective between calcium scores, age, and stenosis. However, this was not linear, as you can see. It's very difficult to apply the degree of stenosis with the calcium score. Looking at treatment protocols in primary prevention, when you have calcium scores, there has been a lot of work done on statins with calcium score. However, the end result after many meta-analysis has clearly showed no clear evidence of improvement in outcomes. So prognosis, extremely good if you have a calcium score of 0 in an asymptomatic patient. It gives a high degree of safety to the patient. However, it is not true for somebody who has symptoms suggestive of cardiac disease. And certainly if someone has a score of more than 0, puts them in a very significant risk profile. So if you look at an FRS score less than 10, you can clearly see there are large proportion of patients with a calcium score of 0 compared to somebody with an FRS clinical score of more than 10, where there is a significant number of patients with more than 400, putting both FRS score and calcium score in perspective. In patients with a similar FRS score, you can clearly see they have an extremely low risk for cardiovascular disease and mortality if you have a score of less than 10, irrespective of the Framingham score, compared to patients even with a low clinical risk have a much higher mortality if the score is more than 1,000. In smokers, things are a little different, and you can see that in smokers, there is a large proportion of those patients with a calcium score of 0 who have clinical events simply because the proportion of non-calcified plaques are quite high in this population, and thereby negates the benefit of calcium scoring. In the emergency room, also we see that despite a calcium score of 0, patients, when they did a CT angio or a coronary angiogram, show significant atherosclerosis and significant stenosis despite having a calcium score of 0, again showing you in the population of patients who present with acute coronary syndromes, calcium score may not be the right thing to do as a screening tool. If you're looking at stable patients with myocardial ischemia, these are stable CAD patients, you can clearly see that those patients who did not have ischemia had a higher proportion of calcium scores of 0 compared to those patients with ischemia who had a higher percentage of patients who had more than 100 or more than 400. If you look at calcium scoring in diabetics, and that's a great population to look at along with CAD, you will see the chance of missing a silent myocardial ischemia in a diabetic patient, this is for asymptomatic diabetics, is extremely low if you're going to include peripheral arterial disease screening, calcium scoring coronary, and a nephropathy, that is proteinuria, in your screening workup of these patients, diabetics or asymptomatic. The chance of missing silent ischemia is extremely low. We've been talking about the warranty of a calcium score of 0, and clearly this is a fairly recent data showing that in a diabetic population, the warranty extends to only 5 years if you have a calcium score of 0. However, this goes to almost 15 years in a non-diabetic population, showing you that the calcium scoring may not be the best thing in diabetics because your chance of developing non-calcified plaques are quite high. Regarding repeat calcium scoring, there has been a discussion prior, and despite using various algorithms and data, at this time, a repeat calcium scoring is not recommended because of, number one, radiation. Number two is that every time you scan the patient, depending on the heart rate, depending on the weight of the patient and the protocols that are used and the machine that is used, you could end up having a slightly different calcium score. What is important is a patient who has clinical risk factors. It's been seen that if he has a high calcium score on the CT, it helps in improving his compliance with medication. And this was done by Matt Budoff's group in 2006, clearly showing that the calcium score can add to the compliance of patients. The Eisner study by Dr. Berman's group clearly showed that if you do a calcium scoring, it helps in decreasing the risk of heart disease without really increasing downstream tests and costs. And most importantly, actually the drug cost went up in the scan group because more of these patients started taking their cholesterol medications better. So the use of calcium scoring for downstream investigations, again, put calcium score as in a very favorable sort of manner. And this is some data with one of my groups where we have actually applied machine learning to calcium scoring, and this is about 6,000 odd patients that were taken up, and using the artificial intelligence algorithm of convoluted neural networks. And what we found was that we can actually pick up the calcium score easily, even in patients who did not have a properly done calcium scoring. Just a simple lung CT, for example, if it was done and applied with AI, you could actually get the calcium score. So this makes it very much democratic, and a lot of patients could actually benefit with this. When they're going even for a lung CT using AI, you can actually get this image. My last slide is obviously a big thank you to my mentor, Dr. Berman, who visited a lab some time ago. And this is what he has to say, and I will just repeat. The recommendation by major professional organizations in cardiology that coronary calcium be measured is likely to have as great an impact on saving lives as the recommendation that cholesterol be measured and controlled. So thank you very much, ladies and gentlemen, for your patient listening, and hope you benefited with this lecture. Thank you.
Sir, patient on statin, and if you go for calcium score, does it give a wrong, false positive report?
Can we save the question till the end? Johann, can we save the question till the end? Just make a note.
Yes, so we're planning for the questions at the end.
Yeah.
Can I just suggest that we are far behind time, and each talk is like half an hour. So what is the time frame that we're talking about?
We have given 15 minutes, Dr. Ashok said, to each and every thing, but we are going behind the schedule.
Well, we 1.5 hours into it, we've got 3 talks. That way, I think we'll finish the session at 10:30. So I think either we stick to time or have this another day.
Sure.
Next,
go ahead, Dr. Prabhu. Can you introduce Dr. Mahapatra?
Yes, I would like to introduce my great friend, Dr. G.N. Mahapatra, who heads the Department of Nuclear Medicine in Seven Hills Hospital in Mumbai. He founded the World Federation of Cardiac Imaging and Clinical Cardiology, Cardiological Society of India. And we'll see, he will be enlightening us about PET imaging, the detection of heart plaques. Over to Dr. Mahapatra.
Good evening, chairpersons. This is a little bit a new thing which I'm just presenting. Okay, PET imaging, detecting heart plaques challenges from other imaging techniques. So all of our present understanding of the major cardiovascular events is centered around the atherosclerotic plaque and the process that leads to acute plaque rupture, producing myocardial infarction. Plaque composition determines its fragility and its further progression. Plaque biomarkers can clinically provide crucial information regarding the vulnerability and the degree of progression. Advancement in recent years have focused on identifying these vulnerable plaques using invasive techniques like OCT, IVUS, supplemented by non-invasive techniques such as coronary CT angiography, which you just now had, and calcium scoring, and molecular imaging with PET tracer, which I am going to a little bit tell. Advances in the cellular molecular biology of the cardiovascular system have helped to user in a new modality in nuclear cardiology, that is molecular imaging. Nuclear cardiology procedures has distinct advantages over other diagnostic imaging modalities, such as having a low radiation risk because of low amount of radio tracers we use. I'll just tell you in case studies also, being relatively painless and non-invasive, provides both structural and functional information of the organ of interest, superior to other non-invasive and invasive tests like MDCT, MRI study with a sensitivity of 93% and specificity of 95%. New innovations such as molecular imaging now offers an array of tools to develop advanced diagnostic approaches. Understanding the pathophysiology of atheroma makes it possible to identify vulnerable plaque based on its metabolic signature or the presence of excessive apoptosis. Because of its larger metabolic and apoptic signal, even we can visualize the small atheromatous plaques in this PET imaging. Recent advances in hybrid imaging technology and a combination of high spatial and anatomical detail with molecular assessment of the disease activity, this provides the ability to identify vulnerable plaque characteristics and differentiate active, that means hot, unstable from the quiescent, stable disease to improve patient risk stratification. Inflammation within the plaque has been extensively documented, and imaging of F18, FDG, that is the oncology agents and the viability agent of the heart, has been tried to different vascular territories with limited success, as physiological uptake of FDG in the myocardium makes it difficult to categorize coronary vessel, even if certain preparations to do the imaging of the FDG. So, who are the patients to be benefited? Acute coronary syndrome. Acute coronary syndrome in the process of MI group, continuous chest pain lasted for more than 30 minutes, new left bundle branch block, elevated cardiac markers like troponin T, chronic stable angina, CSA, with a positive treadmill test, then abnormal myocardial perfusion scintigraphy. What are the exclusion criteria? Who cannot be subjected to this type of plaque imaging, not with other imaging like CT and other things, and in nuclear also. Patients with pregnancy, history of allergy to iodinated contrast materials, history of renal dysfunction in post-MI with serum creatinine more than 1.5 mg per dl, inability to hold breath and following instruction while performing the scan, maybe having some chronic obstructive air disease or chronic pancreatic disease. Patients with arrhythmias, particularly of post-MI and hemodynamically unstable. Detection of the unstable plaque from the stable coronary plaque. Analyze the napkin ring sign, what Dr. Priya has already mentioned, that peripheral high density it is nothing but a peripheral high density enveloping a low density patch of CT values less than 130 Hansen units. The napkin ring thickness, then plaque CT attenuation, then degree of lumen stenosis. So characteristics, what are the characteristics of the unstable plaque detected in CT? Napkin ring thickness thinner than the stable plaques. The napkin ring sign is more frequently observed in a study, a recent study called unstable plaque is 89.2% than the stable plaque is 22%. More severe lumen stenosis or occlusion is 70.3%. Optimal combined threshold of the napkin ring sign and the plaque CT volume of 53 Hounsfield with accuracy of 80.9% to predict a unstable plaque. So this is a case where you can see the Leadman lesion. There are multiple lesions of these things, and then in the IVUS you can see the Leadman plaque, and the lower C and D is the napkin. D is the thickness measurement, volume measurement, and this is the napkin side of a atheromatous plaque. So what are the radiopharmaceutical used for PET imaging? First, we tried with 18F fluorodeoxyglucose, then 18F sodium fluoride, which is currently in force, then gallium-68 dotatate, which is a onco-imaging agent, which also people have tried, then C11PK11195, then 18F fluorocholine, then 18F fluoromisinazole, and then 18F RGD K5. These are the things which are on the trial. So coronary PET imaging has previously been limited due to poor spatial resolution, partial volume effect, and cardiac motion. However, with improvement in scanners in the course of time and development of advanced motion correction software and co-registration techniques, many of these limitations have been overcome. So first with 18F-fluorodeoxyglucose. PET F18 FDG has been used in oncology for many years and was first utilized to image atherosclerosis in the carotid artery in 2002. It accumulates intracellularly in tissues with high metabolic activity, and it does not have any affiliation with microcalcification. Now, you have to see here, it does not have any role with microcalcification, occurs in atheromatoous culprit plaques, which is very common, except an affiliation due to macrophage infiltration, means some degree of inflammation as a part of inflammation, and therefore been used as a non-specific marker of vascular inflammation in aorta, carotid, femoral, and also coronary. But coronary is very poor. Coronary artery uptake is often obscured by the adjacent myocardial signal, which is the main limitation, even despite dietary restrictions of high fatty diet with low carbohydrates. The preparation we do for amyloidosis and other inflammatory disease of the heart. So next agent is called F18 sodium chloride. This is the upcoming agent where the study has shown 18 sodium chloride has been used as a bone tracer for a long time for detection and detection of bony metastasis in many decades, but has now found a potential application in hybrid cardiac imaging. The ligand of F18 sodium chloride is a hydroxyapatite, a key component of early vascular microcalcification. The microcalcification in a atheromatoous plaque is a very common concern. It has to be there, otherwise the F18 sodium chloride cannot be tagged, as it binds to micro rather than macro. See, first when a atheromatoous plaque form, first spotty calcification, microcalcification, then slowly the calcification increases and everything, and then it is converted to a stable plaque where F18 sodium chloride is not picked up. So microcalcification is thought to be an early healing response, as I have just now told you, to cell necrosis and inflammation that precedes the development of a larger macroscopic deposits of calcium, which can be converted to a stable plaque. Microcalcification with a thin fibrous cap is very common in atheromatoous plaque, may also increase local stress and destabilize the plaque, leading to rupture. 18F-fluorine sodium chloride appears to have a low uptake in the adjacent myocardium. That's why this imaging modality is very successful and a very high affinity of the tracers for microcalcification. So what is the mechanism of action of focal uptake of sodium chloride plaque? An event-prone coronary plaque has a thin cap with a necrotic core with the presence of smooth cells and macrophages. The lesion is typically non-stenotic and shows features of positive outward remodeling. So specks of microcalcification in the plaque. The initial phase of inflammation sets up within the plaque due to multiple underlying risk factors leading to microcalcific foci, which tends to have a higher risk of rupture. So chloride uptake is an indicator of calcification within a plaque. In that active phase of calcification, leading to penetration of the tracer, the sodium chloride penetrates totally into tracer across the ruptured plaque, is higher in a culprit or unstable than a non-culprit stable lesions. So little bit of acquisition protocols. Patients are injected with megabecquerel tracers. After a gap of 45 to 60 minutes, we image the patient. Images are acquired with hybrid PET CT scanner of 128 slices per second. So 140 to 185 megabecquerel we inject, very low. So low dose non-contrast CT for attenuation correction first we do with 120 kVp tube voltage and 40 tube current. The least mode acquisition of the fluorinating sodium chloride emission PET data with ECG gated cardiac imaging for 10 minutes we acquire. Then the attenuation correction is used for correction and alignment of CTSC and PET image. Then oral metoprolol and atenolol 100 to 50 milligram is administered to achieve a heart rate of 60 to 70 beats per minute. Heart rate has to come in the range of this, otherwise we cannot do. approximately 60 to 70 ml of IV contrast, that is Omniplex 350 milligram per ml is injected by a dual power injector followed by 50 ml saline. Co-register and analysis are performed by using a software. So axial, coronal, sagittal view reconstructed by assessing the F18 sodium chloride uptake. Gallium-68 detected, yes, it is a somatostatin receptor 2 on the surface of the activated pro-inflammatory macrophage on the athermatous plaque. It has been demonstrated that exclusive expression of somatostatin receptor 2 in M1 macrophages within the atherosclerotic plaque shows improved discrimination of culprit and high-risk plaque in both coronary and cardiac artery. Future days to come. So the first case study, a 57-year-old man with a type 2 diabetes mellitus presented with non-ST elevation myocardial infarction and underwent a PCI with 2 drug-eluted stent in the proximal RCA and posterior left ventricular artery. 6 months later, he presented with another non-STEMI infarction. Invasive coronary angiography demonstrated severe in-stent restenosis in the proximal stent and another severe de novo mid-RCA lesion. OCT demonstrated plaque rupture with red thrombus in mid-vessel lesion and aggressive neonatal hyperplasia in the proximal lesion of RCA. LAD has diffuse plaque without obstructive disease. So, with this finding, patient underwent a sodium chloride 18F PET-CT, which demonstrated 3 discrete regions of focal uptake in the proximal, mid, and distal RCA. The highest uptake with increase, we quantitated it. The highest uptake with increased SUV, channel uptake values, was extremely high and was found to be the culprit lesion. In contrast to RCA, the diffuse disease LAD had non-obstructive calcific plaque with no significant uptake without high-risk features of in CTCA and did not demonstrate any 18F sodium chloride. Now see the lesion here. You see the angiography, see the OCT, and you see the multiple areas of the right coronary artery, the increased focal uptake of sodium chloride in RCA territory, showing these are all culprit unstable plaque which can result in MI. Case 2, a patient referred to an episode of chest pain with a presentation of myocardial infarction. He could not be revascularized due to established infarction. 6 months of the post-infarct, he underwent a F18 sodium chloride PET-MR, whole-hearted 3-dimensional contrast-enhanced coronary MR angiography demonstrated severe culprit in the proximal LAD. Extensive near transmural infarction in this territory is seen on the late gadolinium enhancement imaging. Focal 18F sodium chloride uptake is noted in the culprit lesion as well as in the aorta and mitral annulus. See here. I think I will tell you that the resolution in seeing the arteries is much better in CT than MR, but still the artery is showing in the LAD and showing the focal increase uptake. And here the left-hand side black arrow showing the uptake in the aorta. And this is a transmural impact in the late gadolinium enhancement, upper right side image. So case 3, 45-year-old male presented with chest pain, elevated troponin T with ECG changes of ST segment elevation in B2, B5 leads. Sodium chloride F18 PET-CT performed within 3 hours from the presentation. So increased focal tracer uptake of SUV max 1.71 and TBR, that is called target to background ratio, that is 1.36. We calculated that in the culprit plaque in short axis, coronal and sagittal fused image in the proximal LAD. Subsequently, invasive angiography revealed proximal plaque where the patient underwent a PCI to the proximal and mid LAD. You can here see the plaque imaging here in slices and also a proximal end of the LAD lesion. This is a last case study 4, 60 years male with chronic stable angina and TMT positive and ECG changes underwent F18 sodium chloride PET-CT shows thickly calcified plaque encroaching the lumen of proximal LAD and mid RCA. We find mild increased focal tracer uptake is noted in the plaque where the SUV max is very low, 1.2, and the target background ratio is 1.0, and RCA is also very low. So it is a non-stable plaque. You can see here. There is a calcification in the RCA and also the calcification seen in the territory of the proximal LAD, but there is no increased uptake of sodium chloride. So this is considered to be a stable plaque. So, and this is an event-prone region. The low attenuation spotty macular has a high risk of progression, slice thickness, and variation in contrast opacification. CTCA techniques should be performed, such as breath holding, to avoid artifacts. These are the limitation of the CT. Combined with a supplemental marker in the form of sodium chloride PET may lead to the identification of these high-risk plaques more thoroughly in multiple vessels in just a single setting without any radiation at all. So, concluding, nuclear cardiology is no doubt the state-of-the-art procedures in the present day clinical practice in diagnosis, prognosis, and guidance of therapy in CAD and non-CAD patients. The field of cardiovascular atherosclerosis imaging is burgeoning with increased availability and uptake of CT, PET, and CMR. All are non-invasive in particular. Hybrid imaging platforms combine these modalities with PET, which together provide detailed information about coronary anatomy, flow, plaque morphology, and disease activity, expanding our pathophysiological understanding of atherosclerosis and improving risk stratification. It gives a magnitude of uptake quantified. We quantify in terms of SUV max and target background values TBR is higher in the MI group as compared to the chronic stable angina group. Further, the fluoride uptake value in magnitude can be used as a criterion to differentiate between culprit and non-culprit plaques in MI patients, useful in cases of the multivessel disease. Detailed overview of all the novel tracers for plaque characterization as discussed in today's presentation will have a sufficient space for its future growth and further studies, especially in this threatening era of multimodality imaging techniques such as CT angio, MR in the non-invasive era as compared to invasive intracoronary imaging like OCT and IVUS. Thank you very much for the patient hearing. Thank you.
Thank you, Dr. Mahapatra. And Dr. Chandra, can we go for the next lecture, sir?
Yes, absolutely. The next speaker is Dr. Shah, who's going to talk about plaque evaluation by IVUS. Dr. Shah, please.
Well, can you hear me?
Yes.
Yes, so kindly ask him to permit me to share my screen.
There is a button there. You have to share the screen.
Yeah, but you have to stop sharing first.
Oh,
he did. Go ahead.
Just a minute. Stop share. Okay. Sorry. Yeah.
It's all right.
Now you can do the share, Dr. Saab.
Sure.
Yes.
Thank you. Yeah. Still the host disabled participant screen sharing. Host has disabled me. Can he?
Dr. Mahapatra, you'll have to make Dr. V.T.Shah the co-host.
Okay, for that, what I'm supposed to do?
You need to go to the participants.
Participants.
Okay, up there's a find participant option. Just type his name, Vijay Shah.
Acha, find a participant.
Yeah.
Type his name, Dr. V.T.Shah.
Yeah, only Vijay Shah.
Vijay Shah, right? Vijay Shah.
Okay. Okay.
Did you find his name?
No, I am not finding his name.
Did you type Vijay Shah?
Yeah.
So his name must have appeared in the participant dialog box.
No. I have typed and find a participant in that.
Yes.
Thing, but I am not getting his name.
Nikita, I can see that his name is there. What can I admit?
Yeah.
No, yes, ma'am. Actually, the host has to do it.
Okay. Now I've done it. Done.
Did you make him the co-host?
Yeah. Now I've done it. You have done it. I've done it. Dr. Shah has to unmute.
Can you hear me now?
Sir, he's still. Yes, we can hear you, sir.
We can hear you.
Can I share my screen?
Just a minute, sir. Give us a minute. Dr. Mahapatra, you need to make him the co-host.
Yeah, I've already made.
I cannot see him as the co-host. That's Dr. Vijay Kumar. You need to make Dr. Vijay Shah also the co-host.
Okay, make co-host. Okay.
Yes, make co-host.
Okay.
Yes.
Yes. Okay. Please go ahead. Yeah. You should unmute. Yeah, I have done that.
No, sir, you've not done it. We
Vijay Shah,
cannot
na?
see
Yeah,
him as
I've
the
done that.
Okay.
co-host.
Made co-host.
Dr. Hiremath and Dr. Prabhu, if you agree, should we go to the next speaker and while they are fixing this?
Go to the next speaker, sir.
Okay. Dr. Shah, we'll come back to you once they fix the screen issue. Can we go to Dr. Vijay Kumar for plaque imaging by OCT?
Dr. Vijay Kumar, sir, please proceed.
Yeah. Can you see my slides, sir?
Yeah.
Oh, thank you so much. Good evening, and thank you so much for this opportunity. For the next 10 to 12 minutes, we just see how OCT helps in imaging of atherosclerotic plaques. It is atherosclerosis is a dynamic process with early lesions developing into more advanced atherosclerotic plaque. Evaluation of atherosclerosis has largely been limited to postmortem studies. Although IVUS has provided an opportunity to evaluate atherosclerosis in vivo, it is limited by its resolution of 150 microns. Optical coherence tomography, a high resolution in the range of 10 microns, a light-based imaging modality that has revolutionized our understanding of atherosclerosis progression. So for the next 10 minutes, we'll just cover how this optical coherence tomography helps in identifying different type of plaques. So this produces, either IVUS or OCT produces tomographic cross-sectional images which are similar to histological sections. And how do you characterize the different plots by OCT? We use these 6 features. One is the backscatter, which is nothing but the brightness, attenuation, which is nothing but the penetration depth, and the shadowing. 4th characteristics is composition, texture, and edge or borders. And the OCT is a very useful modality for classification of atherosclerotic plaque progression. However, it cannot differentiate between smooth muscle-rich or collagen-rich intima. Both appear as homogeneous, high backscatter, low attenuating structures. So we use an arbitrary cutoff of a different intimal thickness. Less than 300 microns is normal. 300 to 600 microns is intimal thickening. And more than 600 microns is pathological intimal thickening or fibroathyroma or fibrous plaque. And again, it cannot differentiate between lipid-rich plaque or necrotic core plaque. So both appear as low backscatter, high attenuation with a diffuse borders. And in addition, resolution is not enough to image endothelium. And importantly, it is limited by depth penetration and thus quantification of the plaque volume. So how does the normal coronary artery appear on OCT imaging? This is for comparison. I put an IVUS images here. And here you just see that OCT image, it has produced 3 layered appearance of normal coronary artery, bright intima, a dark media, and a bright adventitia. You see this normal intima is about 150 to 200 microns in thickness. And updated classification of atherosclerosis lesions based on morphology divides atherosclerotic lesions into 4 types. First one is non-atherosclerotic intimal lesions constituted by intimal thickening and intimal xanthoma. The second one is progressive atherosclerotic lesions. There are 4 in this type. One is pathological intimal thickening. Second one is fibroathyroma. Third one is plaque fissure or intraplaque hemorrhage. And fourth one is thin-cap fibroathyroma, the so-called vulnerable plaque. And then there are 3 lesions which are characterized by which are marked by acute thrombi. One is a plaque rupture, second one is plaque erosion, and third one is calcified nodule. And the 4th classification is healed lesions. It is a subclinical rupture, erosion, or calcified nodule, which heal and constitutes the progression of the thrombus. So this is how atherosclerosis progresses. starting with non-progressive lesions, intimal thickening and xanthoma. Sometimes they progress to form pathological intimal thickening. That usually progresses to form fibroathyroma, which in turn progresses to thin cap fibroathyroma. That is the most common cause of ACS, which ruptures and forms thrombus. And sometimes in about 20 to 30% of the patients, these early lesions, such as pathological intimal thickening and fibroathyroma, progresses to erosion, which is a non-rupture form of ACS, and where there is an endothelial denervation, which results in thrombus. This is the second common pathway. Sometimes this fibroathyroma stabilizes to a fibrocalcific plaque, which breaks into pieces to form calcified nodules. When this breaks the fibrous cap, it again causes thrombosis. What happens with thrombosis? Thrombosis either causes acute coronary syndrome, or it may heal. That results in progression of the plaque, which later results in stable angina, sudden death, or congestive cardiac failure. So we just go to the different type of atherosclerotic lesions, starting with non-atherosclerotic lesions. The non-atherosclerotic lesions, two types. Intimal thickening is nothing but accumulation of smooth muscle cells in the intima at the points of maximum shear stress. So it is in the absence of lipid macrophage thrombus. And intimal xanthoma is, in addition, what you have in intimal thickening, there is superficial macrophage accumulation. How do they appear on OCT imaging? This intimal thickening produces a homogeneous, signal-rich intimal appearance, which is about less than 300 to 600 micron in thickness and a low attenuating tissue. This is how your typical intimal thickening appears. And what about intimal xanthoma? Intimal xanthoma is characterized by thickened intima with the presence of superficial macrophages. These macrophages appear on OCT as a series of signal-rich confluent spots with high attenuation. So this is a typical OCT appearance of macrophages. So progressing to progressive atherosclerotic lesions, this is the first progressive atherosclerotic lesion, that is pathological intimal thickening, which is nothing but smooth muscle rich and hyaluron proteoglycan rich intima with the focal accumulation of your lipid. This accumulation is closer to the external elastic membrane rather than closer to the lumen. And it can be without macrophages or with macrophages. This later progresses to fibroathyroma with the development of macrophage infiltration and destruction of external elastic, extracellular matrix with the formation of necrotic core and cellular debris. When it is a focal, it is called early fibroathyroma, which is characterized by the large lumen. And when it progresses, it results in large necrotic core and smaller lumen, that is called late fibroathyroma. Both of them have thick fibrous cap. Here you can just see thick fibrous cap. When it progresses, and a progressive thinning of the fibrous cap with the macrophage infiltration and the paucity of smooth muscle cells, it is called thin cap fibroathyroma. Plaque fissure is nothing but a one-way valve. So it is a small fissure that allows the blood to enter inside the necrotic core, and the formation of plaque and progression of the plaque, but there is no contact of this necrotic core with the lumen, and there is no thrombus inside. So how does it appear on OCT? So OCT imaging, pathological intimal thickening appears as a plaque which is more than 600 micron thickness, and you can just see that superficial signal-rich tissue and a deeper accumulation of a lipid. Lipid is characterized by diffuse, low-signal tissue with diffuse borders. And so you cannot differentiate where it exactly starts and ends. So this is the typical of the pathological intimal thickening. Without macrophages, here you can just see signal-rich spots with a deep signal attenuation. This is characteristic of the pathological intimal thickening with the macrophages. So this is the corresponding histological images. How does this fibroathyroma appear? Fibroathyroma, you can just see that with this signal over region, which is closer to the lumen. So this is a progression into necrotic core rich fibroathyroma. So this closer to the lumen of this signal poor tissue, that is accumulation or necrotic core appearance, that to differentiate this from the pathological thickening. When the lumen is big and the volume of tissue is smaller, so this is early fibroathyroma. When the lumen is small and extensive accumulation of lipid or necrotic core around, so this is your late fibroathyroma. These two are thick cap fibroathyroma because the fibrous cap thickness is more than 65 microns. So So what about thin cap fibrotrauma? This is the typical appearance of the thin cap fibrotrauma. Because of this high resolution, OCT can clearly estimate the fibrous cap thickness. So this is a typical example here. This is a fibrous cap thickness less than 65 microns with a large necrotic core here. And you can just see that here all these macrophages, series of secondary response with the deep signal attenuation, which is again characteristic of thin fibrous cap in patients with vulnerable characteristics. And what about lesions with acute thrombi? There are three lesions which are characterized by luminal thrombus. First one is plaque rupture. Plaque rupture is rupture of fibrous cap with exposure of necrotic core to the lumen and resultant thrombus formation. And a plaque, this usually occurs within cap fibrotrauma. Plaque erosion is occurs usually in the early stages of plaque progression. This is pathological intimal thickening with erosion, and this is early fibrotrauma with the erosion. Here, there is no disruption of the fibrous cap or communication of the lipid or necrotic core with the lumen tissue, mainly result from denervation of or dysfunction of the endothelium. Here, it is protruding nodular calcification that breaches the fibrous cap that forms a thrombus that is the calcified nodule. How these things appear on OCT. This is the histological images. So here you can just see that pathological intimal thickening with thrombus. Here, early fibrotrauma with the thrombus, and here is ruptured fibrous cap and necrotic core exposure. This is a typical plaque rupture, and this is a typical example of calcified nodule. Here you can just see the protruding calcification and attached thrombus. How do they appear at OCT? OCT-wise, this is a classification induced by Jagia et al. Here they divided ACS into three groups. One is with the disturbed fibrous cap. When the underlying fibrous plaque is a lipid, it is called a plaque rupture, which is the most common cause of your ACS, accounts in 65% of the patients. When you don't have lipid-rich plaque, there is a protruding calcification that is called calcified nodule. This is the less common type, constitutes about 2 to 88% of all ACS. And the third one, which is your erosion, which is a diagnosis of exclusion because current technology OCT, which cannot image your endothelium. So how do you define definite erosion? Definite erosion is presence of thrombus in the intact underlying plaque, and probable thrombus is the one thrombus with irregular surface. In the absence of thrombus or in the presence of thrombus, there is underlying plaque which is not visualized, but there is no superficial lipid or calcium of the proximal or distal lesion. It is mainly a diagnosis of exclusion. In addition, OCT can identify other causes of ACS such as tight stenosis, spasm, or spontaneous coronary artery dissection. So what about intraluminal abnormalities? OCT again is a high resolution modality, clearly shows intraluminal abnormalities such as red thrombus, which is a high backscatter, high attenuating intraluminal tissue, and white thrombus is again high backscatter, low attenuating intraluminal tissue. Lake acylate thrombus is mass with the channels and intact media. What are the advanced lesions? Lesion advancement happens due to intraplaque hemorrhage, then healing. Plaque healing is again rupture, repeated ruptures or erosion and healing is again an important mechanism of plaque progression. These plaques can progress either to total occlusion or can transform into calcified plaque. Calcified plaques are two types. One is this plate-type calcification. When these plaques break at the sites of the tortuosity, particularly in mid-RCA, they form nodular calcification. Or when the thrombus propagates and organizes, it forms fibrous plaque. So how do they appear on OCT imaging? This is a typical appearance of healed plaque on OCT imaging. Here you can see that multiple layers with different optical densities with or without presence of the necrotic core. So this is an example of a plaque rupture and healing. So this is, if you see one layer in one healing, so repeated healing, you can see the multiple layers of the different optical densities. So this is a typical appearance of a healed plaque. And advanced lesions again, so this is a typical appearance of thrombus propagated distally and proximally, a subclinical one, which organizes with collagen, which forms the typical fibrous plaque. So OCT cannot differentiate between fibrous plaque and pathological intimal thickening. Both are defined in the same way. And another advanced lesion, so this is a typical appearance of calcium on your OCT imaging. So calcium is a heterogeneous tissue with clearly defined borders and over signal attenuation. So this is the typical appearance of a plate-type calcification, and this is the typical appearance of the nodular calcification. And what about the necrotic core expansion? So it results from plaque fissure or intraplaque hemorrhage. So this is the OCT appearance of your plaque fissure, and this is appearance of the intraplaque hemorrhage, which is appears as a crescent-shaped hypoechoic mass and with clearly defined borders. Both IVUS and OCT have a similar appearance. And what about where are the features of vulnerability? OCT has the highest sensitivity to identify the vulnerable features of vulnerability. So various features of in-cap fibroadenoma is nothing but lipid-rich plaque with fibrous cap thickness less than 65 microns. Lipid-rich plaque is the one where it has lipid or necrotic for extending more than 180 degrees. And the microvessel is nothing but a signal watch about 50 to 300 microns extending for more than 3 frames. And macrophages are series of signal-rich parts with a deep signal attenuation, and the cholesterol crystals are a linear signal-rich tissue with a no deep signal attenuation, and the microcalcification is the one which has occupies less than 90 degrees of circumference. So all these features can be easily identified with OCT. And to one or two studies to show that clinical importance of these features, and this is a recent study which has been from Party et al. Group. So it has shown that the various features associated with clinical outcomes are plaque with MLA less than 3.5 millimeters square, fibrous cap thickness of less than 75 microns, lipid of more than 180, and presence of macrophage. If you have all these features, there is an increased incidence of cardiac death, target LAD segment MI, and it increases cardiac death and myocardial function. And what about the treatment aspects? There are various ongoing trials. The treatment can be of vulnerable plaque, either it is focal, systemic, and the focal treatment is BVS. Unfortunately, BVS is no more available, and it is either with the plaque sealing, regular BVS. And the systemic therapy, different therapies. One is statin, and the other one is estimab. So only parameter which can assess with OCT is the improvement in the fibrous cap thickness. We can't assess plaque only with OCT. So for want of time, I just complete here. So this is a feature. This is a volumetric OCT. This is micro OCT where you can just assess your endothelium, or combining OCT with other modalities such as NARS and fluorescence, or combining OCT with IVUS to improve the deep penetration. The future is bright to do plaque imaging, intravascular imaging with OCT, and then newer features. To summarize, OCT is a promising intravascular modality for evaluation of atherosclerosis. Current technology is limited by 10 micron resolution. It is not suitable for evaluation of endothelium. Does not differentiate between lipid or necrotic or smooth muscle stress, edema versus collagen edema. Future iterations may improve that. Thank you.
Thank you, Dr. Vijay Kumar. Is Dr. Shah ready?
Yes, sir, he's ready. He's the
Go ahead,
co-host
Dr.
now.
Shah.
Yeah, so can you hear me?
Yes.
Yes, we can hear you loud and clear, sir.
And thank you. Now, hopefully, I should be able to share this time. And for a beginning, let me tell you that Dr. Vijay Kumar has made my job very easy. Though you all appreciate that OCT is a very sensitive tool. And I will be talking on IVUS. So I thank Dr. Mahapatra for this opportunity and all the other speakers and faculty. So no conflict of interest. And let me go to the slide mode. Yeah, so today we are discussing about imaging for plaque morphology, both non-invasive and invasive. We spoke about non-invasive and we are up to invasive. And as you all know that people would not prefer to do an invasive test unless it is a must. So the only place we will get to do this kind of testing is when the patient is on the table, especially with an acute coronary syndrome. If he is chronic stable angina, then maybe he has time to evaluate all these non-invasive techniques and then come on the table. But if it is an acute coronary syndrome patient, then is the time possibly that invasive modality will have a chance to study the plaque morphology of the non-culprit lesions, that is the high plaque. So what are the high plaque, high risk plaque characteristics? You heard about TICFA less than 65, large necrotic lipid core, plaque fissuring, rupture, active inflammation by macrophages, cholesterol crystals, significant calcified nodules, intraplaque hemorrhage. positive remodeling, and neovascularization. All these things were shown on OCT by Dr. Vijay Kumar, and I'll try to show you on IVUS how does it look like. The basic difference, please remember, OCT basically requires contrast to be pushed inside, and IVUS does not require. So that is the, besides, of course, the cost in India of IVUS is less than OCT. So one may prefer IVUS over OCT in certain situations. NIRS, of course, is not clinically still used, and we heard a lot about CCTA and PET-CT. So angiography is not the gold standard to determine the plaque morphology. And what I'm going to do is, in short, discuss about the technology available, the morphology and detection of high-risk plaques, the studies and the trials. Meanwhile, IVUS has better documentation of the studies and trials as against OCT, which is a work in progress. And what is the future technology? Some of it which Dr. Vijay Kumar did mention. We all know this is the transducer. The ultrasound waves are used through the transducer, and the sound waves reflection will give us an image, and that is how it would look like. So this technology was way back in 90s, was introduced by Paul York, and the first textbook of 97 was released, where I wrote a chapter on the of the evaluation of atherosclerosis by intravascular ultrasound. And in this last 30 years, from mechanical to phased array transducers, from 20 to 40 and 45 megahertz transducers, the high resolution transducer, which may match the OCT evaluation, what Dr. Vijay Kumar showed, from mechanical pullback to auto pullback. So you have co-registration facilities. Virtual histology has been introduced, and co-registration with angiography and FFR. So this is basically how the intima, media, and the adventitia would be reflected. I'll not go, but Dr. Vijay Kumar showed some slides of this. These are the 4 different slides. Now you, actually the adventitia is the standard against which we compare the ecolucency. So this is a ecolucent with gray flakes. This is a soft plaque. This is equal to this. This is a fibrous plaque, and you can see some amount of thick fibrous or calcification, and you can see here a calcified highly echogenic plate with lot of shadowing. So this is it. Now you can see here, this is almost a 270 degrees arc of superficial calcium with lot of shadowing behind. This is a deep calcium. You can see the plaque over here, and the calcium is deep again with the shadowing. And the most important is to pick up the spotty calcium here and the calcified nodules, which are the predictors of acute coronary syndrome. Now, this hypothesis of positive remodeling or arterial remodeling was amply shown by Glagov, and this is known as the Glagovian hypothesis, which he proved on IVUS, that first of all, the plaque actually is extraluminal, deposited extraluminal. The vessel grows in size, and up to the limit of almost 40% growth can be there without sacrificing the lumen. So if you see here, the lumen is the same here, but the vessel grows in size. And then later on, the lumen gets compromised when the plaque burden goes above 40%. So this is how it is. This is Glagovian hypothesis, which is shown on IVUS, which also you saw on the CT scan pictures. And this is plaque rupture, which basically forms one of the important mechanisms of acute coronary syndrome. And this is how you see here, when the plaque rupture is limited over to the intima, and then when it progresses right up to inside and gives you the pseudoaneurysm like picture. So this is what is plaque rupture on the IVUS. You can see dissection flap over here. This is also one of the mechanisms, spontaneous dissection. And you can see intramural hematomas, as Dr. Vijay Kumar showed you. You can see this both organized and the fresh hematomas. These are the new vessels in the adventitia, which you can see here. And this can be confirmed by what we call as the chroma, by the red. So we can see that this is blood over there. And then on angiogram, it is difficult to differentiate all these features of dissection, calcium, stenosis, thrombus, and sometimes it is organized thrombus over here, and sometimes it is spotty calcium over here, and the same haziness will be seen in both the cases. So IVUS helps you in this. This is chroma flow. As I said, you introduce chroma flow and you will see that the blood, this is representing blood inside the lumen. And if you have a plaque rupture, if you have Mahapatra stents, all this chroma will help. So this was the next technology. And this is also, if you see here angiographic and aneurysm over here, you can put chroma flow and see that the plaque rupture has caused the aneurysm in that case. So then the next concept came about the percentage of plaque burden. So this depends upon the vessel area, the plaque area, the lumen area. You minus that, you get the plaque burden, and as a ratio, you say the plaque burden. So that was the next concept. And the next concept came volumetric. So that is plaque volume. So you take sections of all these IVUS images, and then by the help of calculation, you calculate the atheroma volume. And this was tried in the reversal trial, where a high dose atorvastatin was shown that it prevents progression of the plaque against pravastatin. So this was based on the atheroma volume. This is plaque composition on histopathology, which we tried. Then the IVUS tried to replicate this, and all these features of fibrous plaque, the necrotic core, the fibrofatty, the dense calcium, as you see here. So this is virtual histology almost here, and depending upon the color, the green color is fibrosis, the red color is the necrotic core, the white is the calcium over here, over there. And these are the different things which he showed you both on OCT as well as IVUS. You can appreciate this. Of course, OCT is much more sensitive to detect the cholesterol crystals or the macrophages. But also you can see that on the IVUS also. And as we all know that it is the lipid core and the necrotic core which is responsible for all the sudden cardiac deaths and the MIs which happen. This is again where we see plaque on a bifurcation. Again, another place where we should look for, especially when you get high degrees of MI. So IVUS also has its artifacts, though of course OCT also similarly has some amount of artifacts and negative side. So you can overcome all this with the help of the latest generation catheters and a proper technique which you have. This is the prospect trial. This was the most important trial to prove this technology in case to detect the high risk plaques in non-culprit lesions. So this was a multicentric trial, and PCA of culprit lesions were done, and IVUS was done to detect study the non-culprit arteries, in which they evaluated all the biochemical parameters also, and then they attached certain criteria to that and found out that if you have high risk plaque in the non-culprit lesions, then the MACE rate is very high. And for that, they detected three parameters: a plaque burden of more than 70%, a TICFA which is present, and an MLA of 4 square millimeters. So these were the three criteria, and when you use this criteria, you see that the event rates are much high when all the three are present against a plaque which is quite stable. So this was the feature which then added up, and then they extrapolated this now to the syntax trial. And you all know that the residual syntax score is a predictor of future events. So when you add these features and take those lesions which are residual, then you will identify the high risk lesions which you are supposed to intervene and reduce the events in the syntax score. So this is again the recent trials which are there on STEMI, which tell you where FFR was used, which tell you which lesions to intervene and not to intervene. And this study, which is recently published about a couple of months back, we showed that even in the non-culprit FFR negative, even in the FFR negative lesions, if you have high risk burden, then the event rate is high as compared to those stable lesions. So we are here to find out that which are those high risk plaques, even if they are FFR negative, to be addressed to, so that we can reduce the outcomes in these studies. So integrating physiology and plaque characteristics, some patients with FFR negative will have in the non-culprit lesions develop adverse events, and the number of high-risk plaque characteristics increase with decreasing FFR. So both are important to detect this, and more important is when you have an FFR negative, you study this, you have high plaque features, and possibly they would Now the advances future are very high risk, the high megahertz transducers which will be available to look at the plaques and would then match what OCT possibly the images which give you. Then we have IVUS co-registration. So on the same angiography, you can find out at which place you are integrating. You have IFR co-registration to find out which lesions have ischemia positive or negative. And when you correlate all this, you have now tri-registration of IVUS FFR angiography at one sitting, so that at one go in one picture, so that during interventions you can make help of this. And in the future, possibly both OCT and IVUS, based on their pictures, would be able to give you an FFR technology. So IVUS method of invasive imaging helps to detect high-risk plaques without using contrast, as against what you do in OCT and in this CCTA. IVUS can be used to detect high-risk plaques in non-culprit lesions during interventions of culprit lesions, especially if they are FFR negative. High-risk plaque criteria of TICFA, plaque burden more than 70, lumen diameter less than 4 is established in studies. Future trials will evaluate the clinical utility of IVUS NIRS, which tells you which detects the lipid necrotic core along with the same IVUS catheter, which was tried in the yellow trial, but then subsequently now it is out of repute, and yellow 3, as Dr. Narula said, would again bring back IVUS NIRS catheter. Protect 2 and Prevent trial will establish the concept of guideline-directed medical treatment is good for this high-risk plaques versus implantation of BVS or DS implantation in treatment of high-risk plaques in the non-culprit lesions. Thank you.
Thank you, Dr. Shah, Dr. Chandra, Dr. Shirish to conduct the next lecture, sir. Dr. Hiremath, sir.
Yeah. So next speaker is, I lost the...
Dr. Manoria.
Dr. Manoria, yes. So Dr. Manoria, yes. Stage is yours.
Yes, thank you. Are you able to see the slides?
Yes, sir, you can see.
Dr. Mahapatra, Dr. Chandrashekhar, Drs. M.S. Hiremath, and Dr. Prabhu. For the next 12 to 13 minutes, I'll be talking on this very interesting topic, plaque passivation by drugs moving ahead. All of us know plaques are the major culprit for cardiovascular disease. They put us at risk of heart attack and stroke. And all of us know heart attack is the #1 cause of death and stroke is the #1 cause of disability. But today, the focus of attention is only on coronary plaques. Plaque passivation implies change in the structure or function of an atheromatous plaque to produce a reduction in the risk of rupture and thrombosis so as to reduce ACS. But we are now going a step ahead. We are able to regress plaque also. The last couple of years has witnessed spectacular advances in the field of plaque passivation, both in terms of enhanced understanding and in the availability of a panoply of therapeutic options. When we look at the issue of can we stabilize the plaque, the answer is straightforward, yes. And when we stabilize the plaque, the probability of developing acute coronary events are minimized, and we have seen with several drugs. Can we reduce the buildup of plaque? That is, can we check the progression of plaque? The answer is, I guess, very clearly yes. And the third issue is, can we shrink the plaque? That is regression of atherosclerosis. The answer is yes, as was shown by the glove. But the most complex issues, can we make the plaque disappear? At the present time, the answer is no. Will it be possible in the near future? I think Dr. Chandrashekhar and Dr. Narula are better persons for this. We'd like to have their opinion. Now, all of us are quite clear, and you've been hearing that we know the characteristics of the vulnar plaque, like increased lipid pool, increased inflammatory cells, the fibrous cap is thin, there's reduced collagen, and we know that acute coronary syndrome is caused by rupture plaque in 70%, and out of these, non-stenotic 50% and stenotic 20%. And the non-ruptured ACS plaque are erosion 20%, calcified nodule 5%, and others. But although we are very clear about the vulnar plaque, but when exactly a vulnar plaque will rupture is yet to be evolved out. Now, when we look at the strategies of plaque passivation, we have lifestyle modification, but it's difficult to follow in the long run. Pharmacotherapy is the cornerstone of therapy, and mechanical approaches will be delivered by Dr. Ashok Seth. When we look at the pharmacotherapy, the lipid modulators are the cornerstone of therapy. Statins, ezetimibe, and PCSK9 inhibitors. ACE inhibitors are also useful. Anti-inflammatory drugs, there is some data coming from the CANTOS trial and colchicine, but that is only a preliminary data. Now, statins, as we know, are the cornerstone of therapy for plaque passivation. They are very cost-effective modalities we use in our day-to-day practice. And we must realize that the statins have a panoply of multifaceted actions. They improve endothelial function. They delipidate the plaque, as you can see, before statins and after statins. And delipidation can also be seen on NIS, although this is less oftenly used. But this is data from the yellow trial that statins delipidated the plaque early. Then all of us know the vulvar plaques are hot plaques. You have seen the pictures. And indeed, statins decrease inflammation, decrease high sensitivity CRP. So they are also useful as anti-inflammatory agents. And they also promote calcification of the plaques. And if the plaques are calcified, they are less vulnerable for rupture. Not only this, statins also have pleiotropic effects. And as we know, statins inhibit the enzyme HMG coenzyme reductase. They result in decreased synthesis of LDL in the liver, which decreases LDL, and the decreased isoprenoid is responsible for the pleiotropic effect. What is not often realized that 1 out of 10 plaque rupture culminate into an acute coronary event. And thrombogenicity of blood at the time of rupture is a very important determinant of culmination of a plaque rupture into an acute coronary event. And we know dyslipidemia increases thrombogenicity of the blood, and statins decreases thrombogenicity of blood. So in the event of a plaque rupture, if patient is on a statin therapy, the probability of plaque rupture culminating into acute coronary syndrome is minimized. And it is not only the morphology of the vulnerable plaque, as we said, vulnerable plaque is important, vulnerable blood is important, and vulnerable myocardium is important for a plaque rupture to culminate into an acute coronary event. So focus attention on the other two factors also besides the vulnerable plaque. And one of the peculiar features of statin is the legacy effect. The trial has shown you take statins for 5 years and enjoy the legacy effect for the next 20 years. Time does not permit to go into the details. And the reversal trial very clearly shows you can arrest the progression of atherosclerosis by high intensity atorvastatin. When we are treating patients of acute coronary syndrome, how can we reduce MACE? Reducing LDL by 50% at the baseline, or at least up to 70, achieving plaque stability independent of LVL, improving endothelial function and reducing vascular inflammation. And we have large data on this. This is the Mukashi AIM trial, which was carried out with statins and showed improvement. This is established study, which again was carried out in patients with acute coronary syndrome with atorvastatin and the benefit. And this, the Armada ACS, all of you are aware of, that administering high dose 80 milligram 12 hours prior to PCI and 40 milligram immediately prior to PCI, you can see the MACE is reduced, the periprocedural MI are reduced. And this is the IVUS study of ezetimibe plus atorvastatin that also showed plaque regression. And this is the Miracle study, all of you know, which also showed beneficial effects. You can see 16% reduction in the cardiovascular events, and it is the cardiovascular events, evidence of ischemia requiring urgent hospitalization, which were more decreased about 26%. The PROVE-IT study also showed that atorvastatin produces a 16% risk reduction in the cardiovascular events. And ezetimibe, all of you are familiar with, that ezetimibe on top of moderate intensity simvastatin shows reduction in non-fatal strokes, shows the reduction in non-fatal MI, revascularization, but unstable angina was not affected, and so also the cardiovascular mortality. And this is the GLUGOP trial, which very clearly showed that we can regress atherosclerosis. As you can see on the right side of the trial, the statin checks the progression of atherosclerosis. PCSK9 inhibitors here, evolocumab, produces regression of atherosclerosis. And this is the 4-year trial in patients with atherosclerotic cardiovascular disease, stable, and you can see a 15% reduction in the ischemic endpoint, MI reduced, stroke reduced, so also the coronary vessel. But what is very important is that the curve starts separating after 6 months, be it primary prevention or be it secondary prevention. And this is the OTC outcome trial post ACS 1 to 12 months. And again, you can see a 15% relative risk reduction. But what is very important to realize is that the curves are separating after 12 months, which means you have to wait for 12 months to get the benefit. If the data is analyzed with LDL more than 100, the curve starts separating early and they have more benefit. IVOPEX was a trial where PCSK9 were administered early in the acute coronary syndrome, and they has produced substantial reduction in LDL, 77% versus 35%, but it was not powered to assess the clinical event, but clearly shows that PCSK9 inhibitors can be administered early in ACS. And this is the subgroup analysis of the 4-year trial. You can see if you have a qualifying MI less than 2 years, the benefit is more. If you have a qualifying MI more than 2 years, the benefit is less. And so also if you have greater than 2 prior MIs, the benefit is more. 1 prior MI, the benefit is less. And polyvascular disease, which means if you have disease in all the 3 vascular bed, the benefit is more. 3 vascular bed is right on the top. The red one is the 2 vascular bed, and the last one is 1 vascular bed. And this clearly established that lower is the LDL, more is the benefit. So lowest is best is currently the slogan. Cardiovascular death, MI, stroke. You can see as you decrease the level of LDL, the benefit goes on increasing. The last one, you can see a 31% reduction compared to the top, where the relative risk reduction is much less. Now, these are the guidelines for use of PCSK9 in acute coronary syndrome. To make you still clear, the guidelines say if you have ACS, try high intensity statins, wait for 4 to 6 weeks, see LDL, LDL more than 55, use ezetimibe, wait for 4 to 6 weeks. If LDL is more than 55, then only you can use PCSK9. But problem here, as you can see, if you follow this strategy, you are already waiting for 12 weeks, 4 to 6 weeks after statin, 4 to 6 weeks after PCSK9. And you look at the right-hand side of the curve, start separating in ODC after 1 year, which means when you follow this guideline-based strategy, you will receive the benefit only after 15 months. And we know the incidence of cardiovascular event, the mortality is much higher in the first year post-ACS. So a plea is made to initiate statin therapy in very high-risk patients right at the onset of acute ACS, along with statins, ezetimibe. The patients admitted with ACS already taking high-intensity statin, ezetimibe, LDL more than 55, direct start PCSK9 inhibitors. This has been covered by the guideline, but the other high-risk subset, as you can see on the slide, are not covered. For example, you get an ACS with polyvascular disease. I think we would be reasonable in initiating PCSK9 along with statins and ezetimibe. And so also, if we have recurrent PCI in past, patient now gets admitted with the ACS, very high-risk patients, type 2 diabetes, target organ damage, CKD, CAD, admitted with ACS, or young diabetic in the country, already undergone angioplasty, very diffuse disease, or patient admitted with ACS with LDL very high, 180, 200. So although there may be a difference of opinion on initiating ACS at the time of ACS, but it seems quite logical to initiate at least in the very high risk group, because the curves in PCSK9 trial, ODC trial, they separate after 1 year, and we cannot wait. All of us know AC inhibitors also useful in plaque passivation. If you have endothelial dysfunction, there's an increase in the local mediators, plaque AC increases, and you get all these changes. And if you add ramipril, you can get beneficial effect in the plaque passivation. Now, CANTOS trial was the first trial which showed benefit and was the first trial of proof of anti-inflammatory therapy on top of intense lowering. But although the trial was positive, as you can see, there is increased risk of infection, is cost, and there are several other issues, and is not a recommended therapy at the present state of time. The REDUCE trial also showed very interesting data. It was conducted in patients with cardiovascular disease, diabetes with risk factors, LDL 41-200 on statins, and high triglyceride 130. And interestingly shows a very 25% reduction in the ischemic endpoint, and also a 26% reduction in the secondary endpoint. And the CT EVOPEX trial showed that there are beneficial effects in terms of its effects on the plaque. More work is required with PCSK9. Inclisiran is the new hope for the future, and all of us know it was also touched upon in the earlier lecture. It's a small interfering RNA which inhibits the synthesis of PCSK9, and a single dose of 300 milligram decreases LDL by 50%. This remains there for 6 months. So a 2 injection per year may be the new regime in future, although the drug is not yet approved, but several trials are ongoing, as you saw in the morning. And PCSK9 is a new therapeutic innovation under evaluation again. A single vaccine decreases by LDL by 50%. This remains for 1 year. If this comes out to be a real reality, a booster dose every year may be the new way to minimize atherosclerotic events. So what is the take-home message? Can we stabilize the plaque? Answer is very clearly yes. Can we reduce the plaque buildup? That is, check the progression of atherosclerosis? Yes. Can we shrink the plaque? Yes, the glycol trial. And can we make the plaque disappear? I think this is a question for Dr. Chandrashekhar and Dr. Narula. Will it be possible in future? Statins, ezetimibe, PCSK9 inhibitors are the cornerstone of therapy. Inclisiran is the new hope for future, and so also is the PCSK9 vaccine. And what is the another big message we have learned from LDL lowering is, if your patient has baseline LDL cholesterol above 100, there's a decrease in the mortality. If the baseline LDL is less than 100, there is only reduction in the cardiovascular mortality and no decrease in the cardiovascular mortality, all-cause mortality, as you have seen in the trial of evolocumab and alirocumab. Thank you very much.
Dr. Chandra will go for the last lecture, sir.
Sorry to interrupt, sir. Dr. Ashok said has left the meeting.
All right. So that was the last talk. There is no more talk remaining, right, Nikita?
No more talk.
No more talks remaining. You take the questions, sir.
Yeah. Dr. Chandrashekhar, you have the questions?
The only ones in the chat box, are there a separate set of questions or?
I guess only chat box question, yes.
Only chat box?
You can ask, I can ask.
Okay, so let's go backward. So Dr. Manoria, I think there were a couple of questions for you. Role of nicotinic acid and what level of isolated hypertriglyceridemia do you treat?
Nicotinic has no role in plaque passivation. All trials of nicotine on top of statins were negative trials. The REDUCE trial was positive, and initially there's a lot of encouragement that this is a trial lowering triglyceride has shown benefit. But when the subgroup analysis was done, the benefit was seen even in the triglyceride less than 150. It was same more than 150 in the primary endpoint. And the secondary endpoint, the benefit was more than a triglyceride less than 150. So it's quite clear, although the trial showed benefit in patients of increased triglycerides on top of statins in LDL 41-100, the mechanism of benefit is perhaps not related to lowering of triglycerides, and there are other mechanisms which could be responsible for it. So at the present state of time, we do not have a trial which directly shows that triglycerides high, the cardiovascular events are decreased, and the mechanism of reduction in cardiovascular event is solely triglycerides.
Thanks, Dr. Manoria. Dr. Hiremath, do you have any interesting questions that you see?
Dr. Jonathan, this statin, if you give it over a long length of time, it seems to increase the calcium deposit and the calcium score. Now, how do you relate a high calcium score with a higher possibility of blockages to this?
Yes, sir. A very relevant question. In fact, we've been seeing this lately. As we know, the mechanism of statins is to pacify the plaque and make the thin cap as a thick cap, and in the process also increases the calcification. So this is something that we need to keep in mind when we take these patients for a calcium score, apart from the usual details. Is he on a statin and for how long? So if someone is on a statin for a significantly long period, we do observe, even though this patient has very minimal risk factors, and in some cases, when we take them up for an angiogram or a stress test, either the angiogram is negative, the stress test is normal. So we are seeing this, but I don't think any study has specifically looked at variable as statin in terms of calcium scoring. But yes, we've been seeing this. Somebody on long-term statins, high-dose statins, they invariably have a higher calcium score, and that will definitely affect your interpretation of the calcium score and the risk. Yes, that's true.
The CT angio as a follow-up of stented patient, I think is still good for non-stented areas. What do you think of that? Because you put it under not very useful category.
Yes, sir.
If I get you correct.
Yes, sir. If you're doing a CT angio, which means we're giving contrast, if the stent diameter is more than 3 mm in the proximal portions, a good lab, you'll have a very good sensitivity and specificity for instant restenosis. The problem happens when it is less than 3 mm in a very distal portion. Then it is anybody's guess, although there are some iterative reconstructions that we do. We do some kind of stent reconstructions with a B46 kernel, sharp kernel. We do get an idea, but then it's not a yes or no answer when we're giving that report to the interventionalist. So yes, we have problems with the stents less than 3 mm in the distal portions, but we use some other corroborative tools like the contrast attenuation gradient, for example. So if we find a stent distally and the contrast attenuation gradient is quite acceptable, we are fairly slow. There is no flow limiting lesion, although a mild ISR cannot be ruled out. If you're looking at a stent more than 3 mm in the proximal, CT angio is a great tool for follow-up, and it can be done very easily with good reproducible results. We don't do a calcium score, however, in these patients because they've already had a stent, but a contrast CT definitely.
You mentioned a density score, which is...
Yes, sir. The density score is derived. All labs don't do it. It's a derived score. The machine doesn't give it. We get the area and the Houston units, and then we derive the density score. In 1 or 2 papers, it has been found to be a discriminator in patients who have similar scores. But if you have a lower density, there is a higher likelihood of significant coronary artery disease. But then that's in the minority of labs, and I think there's just only 2 or 3 papers with it.
Dr. Mahapatra, for viability, what would you prefer, a PET scan or an MRI?
We cannot hear you, sir.
Unmute, please, Dr. Mahapatra, please unmute your mic.
So while Dr. Mahapatra is coming online, Johann, I want to make a slight comment on the point that if somebody has coronary calcium more than 400, there's a very high likelihood of a stenosis, and we should think about an angiogram. The data shows that more coronary calcium, you have a higher risk of a coronary artery disease, but the one-to-one relationship is so poor that most people don't suggest any calcium level for you to go for a coronary angiogram. What they suggest is after a certain density, and that keeps varying. Some people say 1,000, some people say 600. After that, the CT scan is not as accurate in predicting your diagnosis. But I think if the audience takes the message that anybody has a coronary calcium more than 400, they should go for an angiogram, that may not be the right message.
Very true, sir. So what I've been just saying is that although we don't know the exact level by which we should sort of recommend another test, so to speak, truly depends on the operator, his expertise in the interpretation. It depends on the scanner. If you have a high-end scanner like Priya was just talking about, we have been reporting even up to 1500, 1600 also. So if it is more distal, if it is less dense, we have the ability to look at it, especially if you have a dual energy scanner. What I was just making a general statement is when we're trying to be cost effective, especially in this country where we have a significant limitation in cost, as the numbers increase, and I just gave the number of 400 based on the previous studies, the operator with the heart team, whether it's the interventionist or the physician, can look at either doing a stress scan, because the likelihood of finding a flow limiting lesion is higher before proceeding onwards. But then this is a lab-based and a person-based kind of approach, which you can look at. To take it forward, CT at today's date and time with the present modern day scanners, 1500, 1600 is not a major issue, provided the density is less and it's more peripheral rather than in the left main region. But then it's the operator's preference and his coordination with the referring physician or the interventional cardiologist.
Right. So most of the data that looks at this come from high-end scanners and very good centers. And in our experience, and that's what the literature says, once you reach those levels, whatever prediction you do is not very accurate. The trouble with personal experience series is not all of these go and have an angiogram. So you never know whether you are right or not. We report things, but you have no way of knowing it's right or not. I agree with doing some other tests that to get an answer, but 1,000 or more, generally in most labs, they think you should be very cautious proceeding with a CT to give an interpretable diagnosis.
So that's all general. So for example, if you have a score of 300, which is localized totally in proximal LAD, we still don't go ahead and do the study. If we think it's occupying majority of the lumen and it's all going to obscure the underlying artery and will not be able to see, we don't go ahead, even with 300. If it is dense, calcified, just one plaque in the proximal vessel. And we go ahead with 1200 score also if it is a diffuse calcified plaques which are distributed in all three arteries. So we go ahead. So it depends on case to case, how dense it is, how it is localized.
You're right, but we have no way of knowing whether we are correct or not, right? I mean, so we can go ahead.
This range actually varies. So there is no absolute cutoff beyond which we do not do, or there is a under which we do.
Correct, but that's the trouble with personal experiences. We don't know whether what we predicted was right or not. But when series looks at this in a regular manner, the general recurring theme is more calcification, less accurate your CT in predicting a diagnosis. So
when we are reporting the CT angiogram, our main aim is either to report it as a lesion which is insignificant or a lesion which is significant. These are the borderline lesions which are the ones which give us problem. So if I see a plaque which I am not sure, which will make my findings ambiguous, I would rather not go for a CT angiogram and ask for a catheter angiogram to be sure.
Anyone can help us decide based on CT angio. Let's say somebody has a total occlusion and there are some collaterals and there is an intervening portion. We have multiple choices like choice of wire, choice of technology, whether to use rotablator or lithotripsy. So does CT angio help us decide what is going to be the best modality for a given case?
Yeah, so go ahead.
Go ahead, sir.
Go ahead, Priya.
Yes, sir. If you see a total occlusion or you see a meniscus sort of appearance, so it does tell you, yes, whether you can, that is what we use for the peripheral interventions also. So it does give you an idea. If you have a little bit of peak, you are more likely to cross. So that does help to some extent. But all said and done, for CT and the chronic occlusions, the use of CT only for chronic occlusions, at least in our institute, it's not preferred. Doing CT. They rather rely on doing, other injections, other coronary injections, and look at how the vessel.
Dr. Chandra, I have comments about when you are doing a calcium scoring up to 1 to 400, that does not produce a hemodynamically significant perfusion defect on a stress MPI scan. So 400 value of the calcium score is the cutoff. 400 and above, yes, it produces, and that patient needs treatment. Number one. Number two, the answer to Dr. Hiremath is yes, the PET scan scores over MRI. So far as the sensitivity is concerned. Specificity, yes, the MRI is little more specific, but it is PET is called the gold standard in the assessment of myocardial viability. Dr. Hiremath.
Thank you.
That's debatable. The spatial resolution of
special. I know. I told you that
so picking up
score.
subtle fibrosis is
but again, there are series of contraindication, Dr. Priya, in MRI. There are serious contraindications. So nuclear cardiology does not have any contraindication except pregnancy. So we can do cases. Yes, that's not a problem.
So when we talk of plaque progression,
this is a kind of a tough area to argue because people who have their modality will support each other. The important thing to remember is PET tells you a different information, MRI tells you a different information, right? PET tells you what part is alive. MRI tells you what part is dead, right? So depending upon what your question is, you can use your testing mechanism. And secondly, it also depends on how much expertise your center has in each of those techniques. But the field is moving more and more towards MRI, although there is more data for PET.
I guess as interventionists, we would be more interested in knowing what is the viable. So which is the positive?
Whatever data about viability till last 2 years, till up to last 2 years was based on the late gadolinium enhancement, which actually depended on what we could see, what we could discern. But now that we are switching over to T1 mapping, so now it is quantitatively possible to do fibrosis assessment segment-wise also. So now again, these advancements are improving the viability.
Dr. Narula has a yes.
So, Chandraji, just going between this PET and MR weight, the question only is that what are we looking at? Are we looking at viability in terms of the survival after revascularization? Are we looking in terms of improvement in ejection fraction? What exactly are we looking at? So those are very important questions. Are we looking for hibernating myocardium? Are we looking for remodeled myocardium? Are we looking for stunned myocardium? And things like that. So it all depends on what exactly we are looking at, and a blanket answer of differentiating between the CMR and PET is not right. I think it's a much deeper subject in on one hand. And secondly, there is a big study which has just been designed starting in 2021, January, what will be called as a PROTECT study. PI is Dr. Greg Stone, which would be doing the PCIs. They are not going for surgeries in these cases. And there will be an extensive imaging analysis of that, which will be able to tell us about some of the dobute parts, some of the SPECT part, PET part, MRI parts and all. But the fact remains, what exactly or what kind of an altered myocardium are you going to go after, and what kind of an outcome are you looking? So if the ejection fraction is the thing, it's altogether a different phenomenon. Because if it's a remodeled myocardium, even if you say it is alive, it is not going to give you a better ejection fraction.
That's a very, very true comment. In fact, that reminds me of a paper by Narula et al., which looked at all these questions a few years ago. And that is true. But at least till today, what method is secondary to, is there good evidence it changes major outcomes? And we don't have strong evidence that we are changing mortality or making very, very informed decisions about revascularization. The only part that's known is if you have significant dead myocardium, more than 50% of the myocardium on an LGE scan, those people don't do well in terms of improvement of function. That's the only thing that's known. Mortality, so far, we don't have good evidence.
I think stress debutamine should not be good. That's also those who are conversant with the technique. Stress debutamine echo is also good.
It's very specific. Very specific. Yeah.
Dr. Narula, this suppose you find a high-risk plaque and you want to follow this. So when do you propose the patient should come in again for a repeat scan? Is it going to be 6 months, 1 year, 5 years?
So, Dr. Hiremath, the first disclosure here would be that I mean, if it really looks a very angry plaque to you, I probably would want something else to be done to that particular subject. Although there are no data to suggest that. But then, as far as the looking at the plaques is concerned,
no, let's assume this is an asymptomatic patient.
So 6 months is the time that we do the CT scan again. And although most of the studies have 1 year thing, but in 6 months, I think it is a reasonable time after you have changed the medical therapy.
I'd like to have a question for Dr. Narula. Sir, considering that now that increasingly there is evidence that the unstable plaque is, assuming a lot of importance, do you see the role of CT or any other modality for use in patients with high risk but asymptomatic for screening purposes?
Yeah, I mean, like that's what we had discussed. And if you remember, I had shown one of the examples when I presented it, that the patient he came with chest pain though. He was not asymptomatic.
So I'm talking about asymptomatic patients.
Right,
So
yeah. But
they are doing calcium scoring. So do you foresee rule of, say CT angiography in these patients? Normally, now, at the moment, it's not recommended. But.
Right. I mean, again, by the guidelines, you obviously would not do that. So I won't make any dogmatic statement here. But looking at the calcium scoring also, as I said earlier, there is a significant evidence which is now coming, and which probably we would know very soon from some of the larger studies, that even in the absence of the calcium score, you may have a 0 calcium score, but there's a very significant likelihood that you might have the plaque, which may be the high risk plaques there. So basically, what exactly we should do, I personally may have some opinion, but based on the guidelines, I probably would not like to say anything so as to start. Various people starting to do the CT angiograms just because I said that during a conference today.
Because MR though is non-invasive, does not involve any radiation also, but still the visibility of the plaque, the vulnerability of the plaque is not well picked up. So unless CT radiation goes down, probably yes, we'll have to wait and watch.
So CT radiation basically now, there are a couple of important things here. You still are able to do it under 2-3 millisieverts easily.
Yeah,
I mean, less than 1 millisievert is possible. In your hands, probably you might even be doing sub-millisievert also. So I don't see that as a major limitation, number one. Number two, I don't think MRI at any stage would be able to do better than CT angiography. Number three, with the kind of habitus that we have, specifically in the United States, MRI is never going to succeed in terms of, and maybe in India also, the obesity in India also.
The spatial resolution is too poor.
Is very poor. I mean, like the Japanese studies which are there with the T1 times that you have been seeing, in those you are able to pick up the high intensity plaques there, the so-called hips, as we call them as, and they have got very reasonable data, specifically coming out of Osaka from Noguchi and his colleagues. I mean, there are so many papers now from them, and having shown the importance of the passivation of the plaques also. But this is all possibly because of the body habitus than anything else. I think for the foreseeable future, I don't think there is anything else that we should be thinking about in other than CT, or maybe some of the biomarkers which might come up, which might be able to tell us a bit more about the necrotic course.
So, role of aspirin as a primary prevention when there is a family history is very strong, patient is hypertensive, diabetic, would you like to start aspirin as a prophylactic primary prevention?
Primary prevention aspirin is usually not used unless you have a high probability or your risk scores are more than 10% for development of acute coronary events. Otherwise, these days, primary prevention aspirin is not used. Primary means patient should not have suffered from coronary artery disease.
Thank you.
Dr. Priya, what is your comment about non-calcific unstable plaque detection?
So you need a coronary CT angiography for that. Calcium score is advisable. I mean, can be used when the patient is asymptomatic and is having risk factors. But CT angiography till now is not recommended. That is what I was talking to Dr. Narula about. You know, whether at some stage he foresees that as to be used.
But do you feel that the hybrid technology will help here? Hybrid technology of PET CT. Hybrid technology.
Yes, definitely, sir. Definitely. See, I alluded to two features of plaque: morphological appearance, and second is what is happening. The functional
inside the plaque. Yeah.
That is possible with PET. Yes, if you pick up inflammation and you pick up the morphological features, you're doubly sure.
We have to be a little careful, right? There is a research part of this. There is a clinical part of this, right? A lot of what we are talking is the research realm. Whether you can add F18 sodium with a CT scan showing vulnerability, these are interesting research questions.
No, it's not a research. It has been studied and it has been published in the American Journal of Cardiology in 2020 issue from India, from the Postgraduate Medical Education Research for PGI Chandigarh. This is a paper which has been published.
Only thing is that the evidence is less.
I'm sure there are lots of publications.
Not many centers who are
So, yes, correct. More centers.
So the evidence is less, but obviously theoretically it is possible and it has been shown.
No, theoretically, practically it is possible.
No, that's what I mean. Theoretically also,
but yes, definitely
it has been corroborated in some papers. Yes,
it's an emerging technology. It has to come, and it has more number of studies are required. Those things have to be done. Yeah.
Right. So there are a lot of studies that are being published. That's the research part of it. But if you really sit back and ask yourself, even if you take a person with 3 feature positive plaque, right, which we say is vulnerable, its predictive accuracy is very low, both on the CT side and in Greg Stone's paper in Prospect. We are just starting to understand what are vulnerable plaques. But once you make a diagnosis of vulnerable plaque, the chance of that person having an event is extremely small. And you have to look at thousands of plaques to find these vulnerable plaques. So this is going to be the clinical limitation. The bigger limitation is, it is not one place you get vulnerable plaque. You're getting vulnerable plaques in multiple parts of the artery. The Japanese did angioscopic studies, and there are other kind of studies. A person coming with an infarction has 3 vulnerable plaques, ruptured plaques in the territory. The one which clotted was the one which brought him to you. But there are at least 2 or 3 other plaques. Not only that, there's ruptured plaque in the abdomen, there's ruptured plaque in the carotid.
Yes.
And in 6 months later, it will be some other area that ruptures. So if we say we have all these tools and we can go and detect something, it's like taking one snapshot. You don't know what happens tomorrow or day after, right? So this is an exciting area, but since this is a clinical audience, we also have to put it into perspective that none of these are really prime time.
Very rightly you said, Dr. Chandra said it very rightly, that there are other areas. And then specifically, as I showed you in our 10-year study, follow-up study, if you look at 50% of the plaques that have ruptured over the 10 years are those which basically were not the high-risk plaques. And the 50% of the plaque ruptures occur from the high-risk plaques. So eventually, they all kind of equal up in 10 years' time, because we have not been able to see the progression of these plaques. So we have just one snapshot, exactly as Dr. Chandra is saying. And one more important thing I would ask Dr. Jagia, that have you tried to look at what Dr. Charis Antionidis is doing? Have you tried to look at the fat attenuation index around the vessel in the CT scans, so as to identify the likelihood of plaque inflammation, to look at the fat attenuation index perivascularly?
No, sir, we are not looking. We have been talking about quantification of epicardial fat rather as a indicator of inflammation.
Yeah, no, here would be a difference,
but not this. Yeah.
The epicardial would be less predictive as compared to what you will see, and the difference between the epicardial versus perivascular. So perivascular would be more fibrotic in these cases if the artery is inflamed as compared to the remote fat in the. So since
we'll start doing it, so we'll take your suggestion and do it.
It would be something real good for you to start.
Okay,
and see whether it has any meaning or not. Although the differences are so small that I sometimes feel a little intrigued whether it would eventually turn out to be a clinical tool. But if it does, it will be a very good way of looking at inflammation. It's a very nice thought process if it turns out to be true.
Dr. Jagia, can you differentiate only from the non-invasive calcium things, what you are doing, CT angiography or what? A group of patients having chronic stable angina, and another group is acute ischemic coronary incident, ACS, leading to MI. Can you differentiate between the two groups by doing the plaque morphology or plaque things which are doing it? I will tell you what is going on in research now. No. So what we are doing it in research, that we calculate the standard uptake values, what I showed, SUV and target background ratio, TBR. So SUV and TBR values are more high in case of ACS leading to MI, and in chronic stable angina, the SUV and the TBR values are less. Again, we are doing the study, but still it is not yet. More studies are required. So this is an area where you can differentiate non-invasively between the ACS leading to MI and chronic stable angina.
So, Dr. Mahapatra, Dr. Mahapatra, can I share a screen and show you a couple of slides?
Sure.
So
you can just do your share screen.
It probably, if you have time, otherwise.
Yeah.
We can see. We can share.
You can see, no problem.
Okay.
Share the screen.
So here is an example of what you're talking, right?
Yes.
So here is, on the top is the culprit lesion, on the bottom is bystander lesion. All right. Can you see the arrows also?
Yes.
Yes.
Here is dotatate, and here is FDG, right? So in the culprit vessel, and you can pick up non-culprit vessel also, right?
Dotatate and FDG.
Right. So you can see dotatate is more specific here in the non-culprit.
Okay.
FDG is pretty non-specific, right?
Yes.
And you can also show there is difference in TBR values. And the same thing also you can repeat for F18 sodium fluoride, right? So here is the culprit vessel, and it lights up, and it does show a difference, right? The trouble is these are good for papers. So you can see how wide the confidence intervals are, right? And these are a small bunch of patients that they do, and they show pretty pictures and they show that something is possible. But if you have to take this to the clinical area and say the guy with this lit up LAD is going to have an infarct or not in the next few months, that part becomes very difficult, right? And that also plagues CT. Here is the Antonidis study we were talking about, right? The perifat attenuation index. In this study, if you remember, they show nice graphs, right? If you have perifat attenuation more than -70, the curves separate nicely, whether it's called all-cause mortality, cardiac mortality, right? The issue is they did 3 vessels, right? They did LAD, RCA, and circumflex. You couldn't find this difference with circumflex. You found the biggest difference with RCA. So a lot of these are still in the research arena. They are very exciting. We need to study them and get more data in this. But it's tough to say we are at a stage where we can use this.
No, it requires larger data, larger studies, and then only, yes.
Yes.
Chandraji, this
Can
is
anybody?
absolutely, I agree with you on those things. Like even in this, the difference was 69 and 74 household units. You know, like I mean, that's why I was asking Dr. Jagia whether they have done it, because then we would see a little bit more of a real world phenomenon. And what Dr. Mahapatra is saying has been shown pathologically. There is no doubt about it that the inflammation is way more in those who have already, where the rupture has already occurred versus the one where the rupture is supposed to occur, right? So vulnerable plaque has less inflammation, the other one. And it stands to logic what you are saying. But whether it will be doable clinically, whether we would be able to say that this is the cutoff point, as Dr. Chandra showed the large confidence intervals, whether we would be able to demonstrate it in terms of outcomes, I think we wouldn't reach. We would not reach that level of clinical precision. I think the best part is what we have, and specifically the way Dr. Jagia presented. I mean, she went stepwise, like what exactly are we looking at? We do that. That is good enough of the suggestion that we might have. And then, as Dr. Hiremath was describing and discussing, that we have to have a proper clinical correlation, and then go ahead with the pharmacologic passivation, as Dr. Manoria presented. And actually, I wrote to him that whenever I listen to his talks, he always thinks out of box, and he's an outstanding thinker. So basically, the way he was asking questions, I think that is something we have to look forward to, and we have to realize that we have limitations, whether we are imagers or we are clinicians, and there is a lot to be done before we will be able to establish it exactly as presented by Dr. Chandra, that research must go on, but when it comes to the clinical translation, we have to be humble here.
Dr. Narula, any guidelines where they indicate that LDL levels should be moving down from 70 to less than 50? They have not incorporated CT very strongly in any of these guidelines. Can you imagine why?
So, I mean, I tell you that medicine moves very slowly, unfortunately. And essentially, we have not had the guts to, I mean, like you remember, I mean, we started levels from 150 to 130 to 110 to 100 to 70 and now 55 or 50. And so basically, somehow or the other, we have been basing all our bets on what we had seen in the Framingham Heart Study of in 1960s, where we said that, okay, the normal levels are A, B, or C. And we have, so I think we have never been able to move or jump. We have moved very slowly, and which has been very, very unfortunate. So 55, yes, now that the levels are 55 or 50, whatever we are being suggested tacitly, again, there is nothing significant. And I think the best part I see is still the American College of Endocrinologists guideline, where they are dogmatic about 50 LDL cholesterol. And they probably had the guts enough to say that. But I think if you really have to be thinking logically, I think we have to be where we are born with. So whatever I am born with, I should be carrying that. And I'm born with 25.
You are lucky. Suppose you are born with 150, what would you do?
You would be born with 25. You will not be born with 150. Every one of us is born with 25. It's not me. Every one of us is born with 25.
I want the comments of Dr. Chandrashekhar and Dr. Narula on a commonly asked questions by the patients. Asymptomatic patient wants to know what is the risk of acute myocardial infarction in future. Besides the clinical data, what is the best possible information, or can you reasonably say what is the risk of myocardial infarction in future?
Dr. Chandra, because I always ask him this question. So
it's a loaded question. I think Dr. Narula should answer it first. So there isn't a good way to do it apart from what we have as the guidelines, the pooled cohort equation. I don't know what we can use in India, because it wasn't represented in the trials that derived the pooled cohort equation. But that's what we use, right? If my relatives ask this, and I'm speaking on a personal capacity now, not as in any official capacity, I would say you cannot have anything better than coronary calcium at this stage. So I would say to all my relatives, after you go at a certain age, you should get a coronary calcium. And it's the difference between 0 and 1 is like a huge event in your life. And so despite the fact we use the pooled cohort equation and the Framingham scores to predict what will happen 10 years from now, coronary calcium seems to be far superior in predicting outcomes and reclassifying patients than the risk scores. What you could argue, and Dr. Narula gave a flavor of this, is that with both the risk scores and coronary calcium, you are still guessing the risk rather than seeing the risk. Coronary calcium lets you see a risk little more because it shows you atheroma. The next one may be total amount of plaque that you have. The trouble is that then you need a full CT for that. And people are not willing to cross into that territory in asymptomatic patients. So for now, what we have as the best predictive value is coronary calcium. And I got mine done, and I'm sure Dr. Narula advises his patients to do that. I think that's the strongest one.
Dr. Chandra, is it possible the calcium score is 0? Then can you predict, can you say the patient will not have or may not have atheromatous plaque?
No, you can predict that. But why do you care? You can predict that his chance of events in the next 15 years is far lower than anything else that can predict. But if you have a diabetic or if you have lots of risk factors, then the warranty period is shorter, but it predicts a event-free survival with great accuracy.
Then what about the microcalcification?
That is the next frontier. We don't know clinically how that translates into events, and Dr. Narula knows more about this. On the pathological side, microcalcification is thought to be a high-risk indicator for the plaque.
Yes.
But clinical side, we don't have that much data because the only way to pick up microcalcification is F18, and that also picks up other calcification too. So it's a little unclear. Jagat, would you add anything to that? Or
I think you said
Dr.
it very
Narula?
Chandraji, you said it very well. I mean, I think very, very succinctly, you said that pathologically, yes, we may have a different this thing, but F18 wise again, I mean, like there is some evidence, but then would it predict it better than FDG? Would it predict it any other way? We don't know. The only one paper where it demonstrated a little better outcome likelihood, and again, in a small number of subjects, it's not a large study, was the Lancet paper of Mark Dweck and David Newby. Right? Yeah. So microcalcification.
Microcalcification
be able to say much.
Missed by coronary angio, and F18 either dotatate or sodium chloride, or it is in the research stage which will be coming into the practice. Do you feel that this can pick up the atheromatous plaque much effectively than CT angio?
So the only reason I see whether these things will have or which stand to a possibility of making into clinical arena would be if you are trying to look at the total atherosclerotic burden in the body. If you are going to be doing, say, for example, I really want to look at my peripheral arteries, my aorta, my carotids, my coronary arteries, and everywhere, yes, F18 more than FDG, because then you don't have to be suppressing your myocardium and all, would probably be the way to go. And we would be able to probably be able to say that, yes, there is an atherosclerotic burden in the body. So that is the only one place where I think that it might eventually make it to the clinical grade. Other than that, I do not think that it would ever replace the CT angio for doing anything like that, number one. The only other place where we had done one of the very recent paper was in JAC, as you might have seen recently, and that was a very serendipitous finding, but in a large number of patients. So it was almost 500 subjects where we looked at the F18, and we serendipitously found that in the bulbar arteries, the penile arteries. These were the prostate cancer patients where we had an access to F18 imaging as also to the CT scans. And essentially, these are the arteries where picking up the calcification almost becomes impossible because these are such small arteries. But if it lighted up, and if it was 0.5 SUV more than the normal, then we expected it to be 35-fold higher likelihood of having an erectile dysfunction in these people. That was only one place where I found that it was exceedingly informative. But these are all prostate cancer patients and not the normal subjects, so we do not know. It might be a good thing to do the study in a group of subjects with erectile dysfunction. So either they had erectile dysfunction or they developed erectile dysfunction in next 1 year. And we know that 80% of the erectile dysfunction is because of the atherosclerosis, but it has never been demonstrated by an imaging study. So here we were able to find that. And then we are normally able to send our patients for radiotherapy or radiation treatment for prostate cancer rather than sending them for the robotic surgery, just because we feel that the radiation may be better than the robotic surgery. But when we found that there was increasingly higher likelihood of having calcification in their arteries. If that suggests that surgery may be as good. And when we looked at the surgical subjects, there was no difference in terms of whether they would have or they would not have the evidence of microcalcification. So I think it might find some niche areas of investigation where we may be able to use it. But this making the clinical realm to replace CT angiography, I doubt it, at least for now.
Thank you.
Dr. Shah,
Can I ask a chat box any questions?
Can I ask a question?
Yeah, please.
To both Dr. Narula and Dr. Chandra, please.
Yeah, please, Dr. V.T.Shah.
Yeah, so we are talking about coronary calcium, and you say that the patient's age should be above 50 to predict coronary calcium for future events. But actually, in our practice, I'm an interventional cardiologist, and 25% of the times, I think the MIs which we are getting are around 40s. They are not around 50s. And even if we do a routine calcium score, I don't think we'll be able to pick up these patients who would land up in MIs. Would you suggest something else to find out this kind of patients who are likely to be high risk for MI? Besides the usual clinical scores which we do, and as you said, we follow ASCVD risk calculator, though along with the other caveats which they have given.
Jagat, you want to answer? Or?
Chandraji, I think you should also answer it, but I would go and say that Dr. Shah is absolutely right here. That as we are seeing the younger and younger subjects, we may be missing out a lot by calcification. So I absolutely agree with you on that in 40s, and believe it or not, I mean, like under 40, when I feel that there is a significant likelihood of having a disease, I go straight with CT angiography in these patients.
So you raise a very important point here, and this is a fantastic opportunity for you to start a collaborative research program on this. So the reason coronary calcium guidelines say you have to be of a certain age to predict events with coronary calcium is because these have been derived from Western populations.
Correct.
We don't know what the distribution is in an Indian population. And since all of you have CT scanners, and between doing hips and knees and spines, you have a few minutes to push through a coronary calcium, this would be a fantastic opportunity for all the people on this panel to collaborate and try to find out what are the prevalent coronary calcium patterns in patients under 40, right? That would be a terrific paper. If you can combine this also further with intravascular imaging in a certain section of population, because my friends in India tell me the people with MI under 40 that you see, they have huge thrombotic burden.
Yes.
And they may not be the traditional plaque ruptures that you are dealing with. They may be an entirely different morphology, maybe more erosions or who knows what, right? And so if you can combine the coronary calcium distribution with an intravascular study, I'm sure good journals will be looking for this kind of a data. And this is a fantastic low-cost project for you to do. Are there something else that you can do? Go ahead, sorry.
No, just to add to your this thing that probably here Dr. Mahapatra also might be able to add the micro calcifications. So, and then as you are saying that instead of just going by the pooled cohort equation, we basically need to add to it what is happening in terms of your air quality index and things like that, which so far we have been just very conveniently avoiding. But for a country like India, and like Vijay.Shah is sitting in Chennai, and Dr. Mahapatra is sitting in Mumbai, I think AQI addition to the PCQ, I mean PCE, might be a big deal. But please go ahead. I'm sorry for the. I
have one or two comments. Yeah, before you say that, one is of course you said air pollution. In this lockdown, Mumbai, I stay in Mumbai, in the heart of Mumbai rather. The air pollution index is very low, and we have come down to 20 or 30% of our MI rates, which we had pre-lockdown. So I don't know, maybe one of the factors. But coming to this, suppose, see, to do a large study for this under 40 or under 50 population calcium score, and then look for events. What if I do it the other way around? I can tell my MI patient, okay, please get a calcium score now. And let me see how many of them do qualify for that high risk calcium score. If I do such 100 patients, and maybe if I don't get even 5 or 10 who have the high risk calcium score, then I don't think that it would be a predictor. What do you say?
Yeah, no, that's a good idea, except that your friends would put maybe 40, 50, 60 millimeters of metal, and then you can do coronary calcium.
Right.
So the other thing that is coming up is this polygenic risk score, and so that seems to be adding to the traditional risk factors, but that again still is mostly in the Western populations. That is one area that you might start reading more about and seeing to finalize the prediction a little better.
And Chandraji, to add to that also, what Dr. Shah just said, that there's a 20-30% reduction in the MIs. I think that proves that the AQI has an important role, number one. And number two, when you said the polygenic risk score, I think the important thing would also be, when we are going after the genetics, if we could also pick up something like CHIP, the clonal hematopoiesis of indeterminate potential. I mean, that is way more likely to be abnormal in Indians, although we have never done the CHIP analysis in Indians. The reason being that the oxidative stress for what we eat, and again, the air pollution. I mean, these are the important things which may be having the epigenetic impacts. And if we have that, it probably might be a very simple way of doing it. And you could just simply go ahead. It may not be that you have done you will be able to have the useful information on calcium, but you would be able to have the useful information otherwise in 100 people who have had the heart attack before 40.
Right. So Dr. Manoria and Dr. Jagat, this is a good one to write to ICMR. I'm sure they'll be happy to fund these kind of studies.
Yeah, sure. Okay. No, I think Dr. Manoria, you should take lead, and then we can all follow you. He is good at organizing all these things.
Okay, if there is no other question, so a big thank you to Dr. Jagat, Dr. Chandrashekhar, Dr. Manoria, Dr. V.T.Shah, Dr. Priya Jagia, Dr. Prabhu, Dr. Vijay Kumar, everybody, and all the attendees, and a big thank you to everybody. We look forward on behalf of our World Federation of Cardiology, Cardiac Imaging, we would like to have other such type of gatherings and everything. And we'll stick to the time so that the time delay will not happen. Okay, thank you so much, and thank you. Special thanks
Thank
to
you, Dr.
Narula.
Thank you, Dr. Mahapatra, Dr. Chandra, and Dr. Narula for your
From all
special
the way to
appearance.
US and spend your very good for your.
It was a learning experience from Dr. Jagat Narula and Dr. Chandra.
Yeah,
amazing.
Nice.
Thank you. Thank you very much. For
very
this.
early morning at 8 o'clock from Minnesota and 9 o'clock from New York. Really, we are really obliged and thankful to you.
Thank you.
Thank you, everybody. Stay safe.
Thank you.
No
Stay safe.
problem.
Thank
Bye.
Thank you.
Thank you. Bye.
Bye.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.